Let's bring the Senate Health and Human Services Committee to order, and if Senator Mike Hodges would open us up in prayer, please.
Pray with me, please. Dear Heavenly Father, thank you for the many blessings you've bestowed upon us. Thank you especially for the opportunity to live in this beautiful state. Be with us today as we deliberate. Lead us and guide us and grant us your wisdom as we make decisions affecting the people of the state of Georgia. In Christ's name we pray. Amen.
Thank you, Chairman. We had this called meeting for the Health and Human Services for basically healthcare infrastructure. Excuse me, my allergies. Infrastructure discussion. I mean, both the healthcare, as with everything, there's nothing perfect. It's the good and bad. We've had some really good news when it comes to DPP, a directed payment plan. And raise your hand in the audience if you have heard of DPP, or directed payment plan, if you have heard of it. So that's probably half of you if you participated in the hand call there, which is well, I'm sure we'll hear a little bit about that. If not, we'll bring it up and further discuss it later. So we've had some good news with directed payment plan. We've had good news when it comes to MCG. We've had good news when it comes to the unwinding of Medicaid, just coincidentally happening at the time that the Medicaid waiver through the ACA is just starting in July 1, relating to access and pathways. So we have good news, and nothing is perfect, and we're here to discuss that, keep it open, transparent, and we're going to limit everyone's discussion to 15 minutes, and we're going to have questions and answers. I'm not going to put a time limit on that, but let's be aware that this is not an unlimited discussion. I want to be out of here by noon. Some of us, including Senator Hodges, has a 4.5-hour drive back to the coast. So without further ado, let me before I call the first speaker, I do want to say there is a little change in the schedule because of the discussion relating to Atlanta Public Safety and the City of Atlanta having to get back to there for a vote today. I understand they've asked to be moved up, but we're going to go ahead. We're going to go with Chairman Robert Pitts and Fulton County Board of Commissioners Jessica Corbett Dominguez, and then we'll go with the City of Atlanta and then back on the order that we have listed on the schedule. So Chairman Pitts and Commissioner Dominguez, the floor is yours. We're not going to hold up signs about 15 minutes, but we will. But if you would be respectful of that, we'll try to keep you on track and try to give you warning ahead of time. Thank you for being here today.
Thank you, Mr. Chairman. I will be brief as usual. Good morning, sir, and members of the committee. Thank you for having me here today. Again, I'm Rob Pitts. I chair the Board of Commissioners of Fulton County, and with me this morning is Jessica Corbett, who is our Director of External Affairs. Fulton County is home to 1.2 million residents in 15 cities, and also hosts about another million visitors at any time, any day, comprised of workers, students, and tourists. But we're working to ensure that our citizens and visitors have access to health care throughout Fulton County. And as you can imagine, the closure of the two WellStar hospitals, WellStar South and Atlanta Medical Center, has presented challenges for our citizens in Central and South Fulton County, but also throughout the county. Earlier this year, in that light, we conducted a study in partnership with Morehouse School of Medicine and Ernst & Young. We wanted a third-party independent look at it that ultimately revealed a health care desert in a large portion of our county that results in poor health outcomes for a great number of our residents. And we believe that no one should suffer because of their zip code. In fact, our neighbors to the north typically live 5 years longer than our citizens who are in the southern part of our county. And that's why I say that no one should die early because of their zip code. Now, Ms. Corbett will go into a lot more detail. We're taking steps to address this health care desert, And in some cases, it sort of resembles healthcare redlining. First, we're in the process of opening a primary care facility with Morehouse School of Medicine in the city of East Point. And our partner in providing care for our indigent population, Grady Memorial Hospital, we plan to open 2 additional clinics this year. And just for the record, over the past 50 years, we probably contributed more in excess of $2 billion to Grady Hospital. But beyond traditional healthcare needs, we're also taking steps to address our behavioral health needs, which is a topical issue nationwide. We recently launched a new mental health care mobile unit to connect residents with services wherever they may be in Fulton County. We're very, very proud of this initiative as well. And with the support of President Pro Tem Jan Jones, we will open a behavioral health crisis center in 2024. The state's providing funds for us. We provided land and a building. So thank you for inviting us here today to be part of this important conversation. Now I'll turn it over to Ms. Corbett to elaborate on the healthcare infrastructure picture in Fulton County.
Thank you. Good morning, Chairman Watson. Good morning, everyone. And thank you, Chairman Pitts. I also want to acknowledge our county manager, Dick Anderson, is here with us and certainly has been very involved in this work. Kaylin, can I use the clicker? Okay. So I'm just going to go over, again, a few of the things in a little more detail that the chairman just discussed. This is really building on many decades of work that Fulton County has done around health equity and looking at social determinants of health in our community. Here from the study that Chairman Pitts just mentioned, which was conducted in coordination with Morehouse School of Medicine, which is the only of Georgia's medical schools located within Fulton County. This kind of shows you a little bit of a racetrack, if you will, of the kinds of assets that are part of our health ecosystem. And certainly Fulton County is blessed with many resources, but those that are highlighted here in yellow are among the resources that were affected by the closure of 2 hospitals within Fulton County in the last 12 months. And so we'll go into a little bit more detail about how those closures had a disproportionate impact on some of our citizens. And as Fulton County does this work, really our goal, working with Morehouse School of Medicine and many other partners, is to create a healthcare system within our county that meets the needs of all of our citizens and is really based on equity and access. And this is really the what I would say is the most jarring of the discrepancies that we identified in the work with EY and with Morehouse School of Medicine. As Chairman Pitts discussed, the life expectancy difference of 5 years between North Fulton and Central and South Fulton is jarring. When we think about South Fulton, we are not talking about a remote corner of the state. We're talking about the communities just outside of the world's busiest airport. We're talking about the headquarters of major Georgia companies like Delta Airlines, Chick-fil-A. So this is a community where hundreds of thousands of residents have no hospital in their community. And again, I'm going to talk a little bit more about the differences in social determinants of health that are already layered on to these hospital closures. So here, when we look at what we define as the healthcare desert that you see here on the left side of the slide, it is true that some portions of this are lower density population. However, that Central and down into East Point, these are communities that have a rail line, they're home to major employers, and tens of thousands of residents. So just as we are looking at our water infrastructure, our road infrastructure, we need to plan for the health infrastructure of residents today and in the future, both to meet the needs of residents, but also for those larger infrastructure needs of the community as a whole and its ongoing vitality. Just wanted to dig in a little bit deeper about the per capita rates of care, and really looking at the bottom of this slide. In South Fulton, there are 0 practicing cardiologists, 2 practicing oncologists, 0 practicing pulmonologists, 0 practicing infectious disease specialists. 10% of the mental health practitioners that we have in Central Fulton, and 6 neonatal practitioners. So the difference in one part of our county compared to others is jarring and concerning to all of us. As I mentioned earlier, there are layered on social determinants of health, including access to housing, employment, educational access, and quality, and other factors. 12 of the zip codes that are affected are medically underserved, meaning they have a high prevalence of underinsured residents. We have intranet deserts, where residents have lower access to broadband or lower utilization of broadband for telemedicine resources. We have a percentage of our population who are living in poverty. And we also have portions of this population that are socially marginalized. So the lack of access, the lack of physical access points for healthcare layered onto these social determinants is really what is driving, we believe, that lower life expectancy. I know you're going to hear from Morehouse School of Medicine later today, and I expect they may highlight some of these points as well. The hospital closures in Fulton County have had an impact throughout our county. So not only is this affecting the residents who are within 5 miles, but it's affecting everyone. We are seeing longer wait times at all of the hospitals within Fulton County and in surrounding areas as well. In fact, we're hearing of longer wait times as far south as Macon. So the impact on our ecosystem is far-reaching. So we have, again, working with EY and working with Morehouse School of Medicine, our Board of Commissioners, led by Chairman Pitts, is really taking a look at what can we do? What are the things that are within our control? And of course, collaborating with the state and many of the partners in this room. Excuse me. So one of the immediate first steps is an effort to increase access points in Central and South Fulton County. So that is being done right now with a partnership with Morehouse School of Medicine, opening a new clinical site in East Point. Hey, good morning, Cinder. In addition to that, our partners at Grady are opening 2 new sites in Central and South Fulton as well. And we are also, as we go into this a little bit more deeply, looking at other long-term funding options for healthcare within Fulton County. We have, as Chairman Pitts indicated, provided $2 billion of support to Grady over the last 50 years, and certainly value that ongoing partnership. We are also on an annual basis investing $16 million in mental health resources. Our new behavioral health crisis center will open next year, and thanks to many of you in this room for your support. We have launched a digital ambassador program to increase connectivity, and we have launched a mobile app to help residents connect with resources. We have also, in our work to address social determinants of health, invested this year alone $6.8 million to community-based nonprofits that work on issues like economic stability, employment, housing, and others. Certainly there's much. We feel like we have just begun this journey, much more work to be done, and look forward to working with all of you to address these issues. Thank you.
Thank you very much for the presentation, and very thorough, very thoughtful. EY does a great job, and would like to thank them too. Open it up to questions from the committee. All righty, my vice chair.
Good morning.
Good morning. Thank you very much. I had a question about on the study about the limited physician specialists in South
Yes.
Fulton and where those numbers came from. Was that based on the office address of the people that are practicing? Because normally neonatologists practice at a hospital. So
You're
I'm surprised there are
correct.
6 neonatologists.
I
on
think
this.
that's a very good question, Senator. That is my understanding, that it is based on office address, but if you would allow me to just review that and get back to you, I'd appreciate it.
That'd be great, thanks.
All right, Senator Lucas is on 12.
Yes. What do you expect as far as Fulton County Commission having to spend since the 2 hospitals are closed and now there is what they call a recertification of those folks on Medicare as well as Medicaid? So how much money do you think the Commission of Fulton County will have to come up with just to take care of health care needs where people might not qualify or might not be recertified to receive Medicaid or Medicare?
Thank you, Senator. That's a great question. Our annual cost this year for Grady is $60 million, and that doesn't cover anything you just talked about. And so we're currently in negotiations with Grady for our service agreement for the future. And so they have already made requests of upwards of, Mr. Anderson, $40 million over what we are already investing. And that's just for Grady's needs. That does not address all of that. So I don't know that we have a precise answer to that question, but it's in the tens or hundreds of millions of dollars that local hospitals have already approached the county about. We don't have those resources as we sit here today, so those are some of the very hard issues that our Board of Commissioners is grappling with and looking at different funding mechanisms. So, Mr. Chairman, is there anything you wanted to add to that? Thank you.
Orrock, you want to use Senator Lucas, number 12?
Thank you, Mr. Chair. Thank you so much. And I'm familiar with the information that you've received
Yes,
because
ma'am.
we've met separately, and I just want to appreciate the leadership over in Fulton County on addressing this healthcare desert. And I know that this is not a new topic. The county leadership under Chairman Pitts has been engaged vigorously in efforts to mitigate and address this healthcare desert that has been identified so thoroughly in the Morehouse report. It's a real question, I think, for the corporation out in Marietta, Wellstar, about when they're going to come to the table with their money on this, because it is their actions that shut down a Tier 1 trauma care hospital and walked off and created this healthcare desert and took down, 15, 18, 20 practices in addition to the 2 hospitals that have been serving our citizens. And what Morehouse, of course, pointed out is the impact on Black and brown communities, and the fact that there's not an emergency room south of I-20 in one of the largest counties in this state. And so that question, and it should be, we'll pose it to Wellstar directly as they are here today, but we're scrambling and facing an increased burden on Fulton taxpayers, and not to mention all the people that are going with little or no access to health care. That conversation needs to be stepped up about this huge corporation that has $2 billion in assets and is spending like a some would say a drunken sailor, but $1 billion on record in our local newspapers about what they're planning to do with their money. And it's not, at this point, does not include investing in addressing this healthcare desert. Is the county optimistic about bringing Wellstar to the table to bring real dollars to this so that it's not an additional burden on a county that's already putting billions into healthcare?
Cinder, that's an important question, Chairman. I don't know if you want to answer, but I will say this. Fulton County has joined in complaints against federal complaints against Wellstar based on some of the concerns that you've just expressed, and I don't know that we could comment on that publicly as those are pending, unless Chairman Pitts would like to add anything to that. Thank you.
Yes, thank you very much. In addition to that Department of Justice complaint.
Yes, ma'am.
And really a strong step taken by Chairman Pitts in the county. In filing that complaint, there are also complaints to IRS that they're in violation of the 501c3
Yes, ma'am.
requirements of a nonprofit hospital, as well as complaints to the Office of Civil Rights at HHS. So
Thank
this
you,
matter.
Senator Allred.
Thank
I
you.
appreciate that.
Thank you, Mr. Chair.
Yes.
Thank you.
Thank you.
Any other questions? The Chair of Finance is,
So I'm not sure exactly how to address this, but I think the effect of the hospitals maybe haven't been there on the life expectancy because we're looking at historical trends, aren't we? And the other question I would have, and it's a complicated issue, but when you look at racial differences, Asians are about 83 years, Hispanic 77. I was just looking at the numbers. Caucasian 76, African American more like 71. So there's a racial component to that for whatever reasons, I don't know. But I guess I'm asking, have y'all done a deeper dive into the factors other than just say there's a 5-year difference, number one, and number two, do you think that it's going to spread more with the hospitals? Because I don't think we've really seen the effect yet on life expectancies of the hospital shutting down.
Mr. Chairman, thank you. That's a very important question. So to your point, the communities that were affected by these closures are primarily communities that are African American, and not in South Fulton, that is 90% plus. So you are correct that there is a disproportionate, there are existing disproportionate health outcomes among people of color in this country and in our county. And these two hospital closures disproportionately affected African American communities. And therefore, we do expect even worse outcomes than what we already see. To your point, this is historical data. And so we are concerned that that people of color in Fulton County will have even worse health outcomes than they already do. There are, unfortunately, many other complicated socioeconomic factors that are, and that's really what social determinants of health are all about. And we've taken a hard look at that, and you're right. Job access, poverty, insurance access, all of those things are additional complicating factors.
thank you. Any other questions from the committee? Senator Brass, you're on two.
Thank you, Mr. Chairman. So going back to that chart, I think it's like your second or third slide, but it's this one here. Okay. So, and this is a little bit of a follow-up on Chairman Hostetler, but so just kind of walk with me here, because when you go, if you follow the chart, and again, this chart, it kind of, as you were going through it and you were going through the lack of care, I really felt like you were describing rural Georgia.
That's right.
Because this is certainly an issue outside of just Fulton, and that part of Fulton is rural, and I know because I represent it. So, so you're certainly hitting home here. But if follow along with my kind of thought process here, and I'll probably come to a question at some point, or I'm going to try to. But if we're looking at the first piece there, the first column, 37% non-white, and then we jump 17% up to 54% non-white, and the life expectancy goes down 5 years. Well, then we jump up 37% to non-white into South Fulton, and it stays the same. So that, to me, says it's not the driver. And then we skip on down to Medicaid, and we're at 5% Medicaid in North Fulton. And then we go to 14% Medicaid, and life expectancy drops 5 years. And then Medicaid jumps up 6%, but life expectancy stays the same. So to me, that's not the driver of that drop. And then we look at uninsured, and that uninsured in North Fulton is 11%, and we jump 4% uninsured, and that's when the drop begins at 5 years of life expectancy. And then uninsured stays the same in South Fulton, and so does life expectancy. So looking at this data, and there's no breakdown here, but looking at just these numbers, it seems to me that uninsured population is the driver of dragging or dropping that life expectancy down.
I think, sir, that I don't know that we can ascribe causality to any one data point on this slide. I think it's a complex.
Right.
A 4% change in an uninsured population, I wouldn't think would equate to 5 years left life expectancy, but I'm not the data analyst here. But I think what we are doing here is describing the conditions in these communities. And you're right, some portions of South Fulton County are rural. The communities abutting Coweta County and Fayette County in particular. But I would not describe College Park or East Point, for example, as rural, and they are also within this area. So I think the story I think we're trying to tell is there were all pre-existing concerns that have now been exacerbated by the 2 hospital closures, and that they're part of that pre-existing condition, if you will, to use a medical term, is a 5-year difference in life expectancy that now we are concerned will get even worse as we have lost some healthcare access, and we are now taking steps to address that.
Well, and I think that helps me come to my question.
Sure.
And I think we're playing Jeopardy because you just gave the answer to my question. But if the uninsured population is the driver, which when I'm looking at this data and these trends, it tells me that is really the data set we need to be looking at. But the uninsured, for most uninsured, their only form of health care is a hospital. And when we lose 2 hospitals, is it not true that now that uninsured, I think we are going to see some much worse.
I think you're exactly right, sir. I think that it's people are seeking care at other hospitals. The wait times are untenable, especially for folks who don't have sick leave at their job or any number of other complicating issues in their lives. And so they are, if your only care is an emergency room and there is no emergency room, or you can't wait in the only emergency room you can get to, you're certainly, we can expect that those outcomes will be affected.
Thank you very much. As you said, it is very complicated, and we're going to move
Yes, sir.
on, but I did want to point out that we had, I think, over 2.5 million people extra on Medicaid rolls. So the uninsured percentage would certainly be less than what it is now. Number 2 is that as we unwind it, and that's going to take more than 6 months to unwind it, they should be rolling into pathways and access. So those 100% to 137%, which were left out of the ACA by the Supreme Court, will be able to be covered. So everyone from 100% up to 400% of the federal poverty level will have access to private insurance that will be supplemented by the federal government. Number two is that those below 100% will roll into the Medicaid waiver, which we called Gateway. Gateway or Access, I get those,
Yes, sir.
whichever ones we made up the name for. But the point is that and those will only require 20 hours of part-time, 20 hours of volunteer, or going to vocational technical school, or going to college. So unless you fail to sign up, there should really be no uninsured, because those who can't do that would be on disability, or should be on disability. So I do certainly agree that in the past, and we're looking retrospectively at these numbers and trying to predict what's going forward. So I think the uninsured numbers will be smaller, but it doesn't take away the fact that poverty is certainly a major player. Why are you in
Yes.
poverty? And that certainly has significant health outcomes when it comes to that.
Yes, sir.
Let's move on, and we're going
Thank
to
you.
move up to the City of Atlanta, Lisa Gordon, and Chief Darren Scheibom. I may have butchered that last pronunciation. I apologize. You can help correct me. But thank you for being here. Thank you for your service, both of you, and thank you for what you're about to do now. And don't envy your job later today. But this is something you've been living with, and I think you've handled well. It's been an unfortunate situation, but let's talk about health care right now.
Good morning, Senator, and good morning, the committee, and all parties here. I'm Lisa Gordon, the Chief Operating Officer for Mayor Andre Dickens, our 61st Mayor of City of Atlanta. We're here to share some information of the impact of the closure of the Wellstar AMC that was effective on November 1st. Here with me is our Intergovernmental Affairs Director, Kenyatta Mitchell. She's in the back, and Chief Darren Scheibom here, and also Chief Rod Smith, who will address EMT and ambulatory care issues that are amplified by this situation. As we learned of the closure, the first thing that we wanted to look at was what is the impact on our citizens, businesses, and visitors to our community with the loss of a level 1 trauma center. Given the current social detriments that were enumerated by Fulton County, one of our partners, as well as DeKalb County, you could see that the amplification is exacerbated, especially when we have many visitors to our city on any given weekend, especially on a holiday weekend. It could exceed 100,000 visitors in addition to the residential populations and the populations in the surrounding metro area. So for us, it was a significant issue that we addressed through convening all of the providers of health care. So we had some sessions also facilitated utilizing EY, and we also did facilitated meetings with elected officials in the counties and cities and other areas affected, including all of those surrounding neighborhoods. And part of that work was to look at how do we communicate to citizens within about 45 days to how do they get to service. We know that there were gaps in primary care, urgent care, and specialty healthcare services in specific neighborhoods. As it was discussed, the social healthcare detriments and health equity issues were amplified in our community in Atlanta, being in the central city, and we have zip codes where we have measured those same health outcomes that were enumerated earlier. As we looked at these matters, one of the things we wanted to do was set up some constant communication with all of the partners. We met with Grady, we met with Atlanta Piedmont, we met with Emory, we met with the FQHCs, as well as all of the partners that provide community centers and other referral services. We set up myhealthatl.com, which was a service to provide navigation to any citizen in the region of where to go to get services. We also partnered with the ARC and Archie to look at a regional healthcare coalition that would extend beyond this one incident, because this could happen again in our community, and so how would we be prepared to address it? There are some specific public safety issues as we have large events or as we have critical incidents, and I have Chief Scheibom here to enumerate some of those issues so you would have the understanding of the amplification of these issues.
Thank you, Chief Operating Officer Gordon. Chairman Watson, it's Sherbaum. It's scary to look at, but easy to say. So, but you can certainly stick with Darren if that's easier. Members of the committee, thank you. I would just bring a couple unique perspectives to public safety, particularly around law enforcement and what the closing of AMC did for us. As you know, we host many, many events right here in the city that has been already alluded to and brought forth by the previous speakers. As we prepare for those, we had traditionally had 2 trauma centers that we would be diverting to if a critical incident occurred. That critical incident could be a bus crash, it could be an active shooter situation, it could be an explosion event. There was always the ability to divert multiple patients to 2 centers so one would not be overloaded, and we have lost that, and I'm sure Chief Smith will be able to speak to that. Most recently, the active shooter in Midtown. We did not have the ability, as we evacuated those that were wounded in that attack, to just 2 trauma centers. They were going to 1, which can easily overload the capability of that facility to be able to provide the care that's needed at that time. We're already preparing for the World Cup in 2026 and possibly a 4-peat of Georgia contending for this national championship in 2025. And so as we prepare for that, we can already see missing in our planning 2 trauma centers at play as we prepare to welcome the world and the nation right here back to our capital city for those events. And then something that's unique that isn't always seen is when we have incidents where there are 2 sides and a few that have engaged in gun battle. And we're fortunate that right now our shootings in Atlanta are down 25% over this time last year, but they're still occurring. When we have gang conflict where 2 individuals or more have been involved in an incident, we have traditionally diverted 1 to Grady and 1 to AMC. We do that to be able to make sure that the conflict doesn't follow into the environment of medical care. And we have lost that capability. Now we have to deploy officers to Grady Hospital to be able to ensure that the medical care can still be provided. While we have 2 individuals that just moments before had been shooting each other, we now have them and their family and their friends in the exact same environment. And this also involves officer-involved shooting scenarios as well. When we've had an incident where law enforcement has been involved in a shooting, we've traditionally diverted the officer to one facility and the family members of the individual involved to the other, again, to lower the tensions, to de-escalate, to make sure the medical care is not interrupted by any reoccurrence of violence. That is not only an Atlanta practice. When we have shootings and incidents across the region where individuals are being brought to Grady and AMC, whether it's from any of the surrounding counties or jurisdictions, that was the same practice that was followed. One party goes to Grady, the other party goes to AMC, and we have now lost that capability. So as this body and others look for solutions, the need for more level 1 medical care right here in the capital city is vital as we continue to host the world and we continue to have that unique role of providing for the public safety of the region. Thank you. Chief Smith.
Good morning, everyone. My name is Rod Smith. My name is a little bit simpler than Darren's to remember, so the name's Smith. I'm here to talk to you briefly about the impact and the need for your assistance to address the medical care environment here in the metro area. What you're seeing is not just a problem that came as a result of the pandemic environment. This has been going on for a decade now. And so what we are looking for is your assistance to help us get past these hurdles. Atlanta Fire Rescue, just like any other environment, we have been experiencing some staffing shortages as well as, like all of the hospitals and the responding agencies. The 2 closing hospitals' impact on the Atlanta region read as following. As a result, 40% of EMS transports that went to those locations that resulted from the city of Atlanta now have to be redirected. What does this look like? Roughly 100,000 patients a year. With 340 to 350 trauma activations monthly, and so we now have Grady as the only location to take them. And so the hospital closure impact drastically impacts the first responder model, not just for Atlanta Fire Rescue, but for the transporting agencies as well as the departments that serve contiguous areas. What we have here is a long wait time when we get to the call. And so our units are standing on the scene in the pre-hospital environment upwards of an hour on a regular basis with no one or nowhere to take them. When I say no one, meaning the ambulances are tied up with wall time in the hospitals, and we have no locations to take them to that are in close proximity. And so what this does is it increases the admissions into the other hospitals in the North Fulton, into the Alpharetta, into the Gwinnett areas. And so we are increasing transport times going into those areas. And so you know that time is critical when you're trying to save a life. And so our goal is to minimize those transport times, and so we can increase the survivability of our citizens. And so we will continue to run the calls, but just know that we do need your assistance because we do need somewhere to take those patients. Thank you.
That concludes our remarks.
Thank you so much. We really appreciate that. Questions from the committee? Senator Hart?
Thank you so much. And I know that the city and the county have both had to take extreme measures and face extreme conditions in the wake of these closures. And I want to appreciate the diligence and the effort that's been ongoing now for some months. Do you have any calculation of what the I don't even know how you quantify what we've just heard from our law enforcement leadership and our emergency responder leadership. How do you quantify the cost to the city at this point, dollar-wise? Because I think that Wellstar should be bringing dollars to the table to address the hole that they left here.
Is there a question there? Thank you.
Yeah, I asked if they had any
Okay. All right.
quantification of the cost to the city.
Is that a readily available figure?
We have not delved into any financial analysis as it relates to this recent impact. 'Cause as you know, the closure was in November, and so we've had about close to 6 months of operation. So we don't have that information available at this time.
Thank you.
And just one follow-up quick question is, and you may not have the answer, but there are those in this audience that can bring it if you don't. But that is, do you know how we compare with our trauma centers here in Georgia, and particularly in a huge metropolitan area? We have one, level 1, tier 1 trauma center here. Do you know how that compares with other cities in our region?
I believe that information is available. I don't have it readily available, so
Yeah.
I would, in a testimony like this, I would prefer to
Certainly.
make sure that information is correct. But
I know that Charleston has 4 level 1 trauma centers in that city, for example.
right.
All right, thank you. We can get an answer on that a little bit later, or maybe
Thank you.
Chief Smith may know. Just a clarification, the redirecting of how many patients are anticipated, or where are we with that?
Approximately 100,000 patients per
Okay.
year.
Wow. Okay. That's what's anticipated, or that's what you're doing? Is that since
That's the
November?
projected number now based on the
Projected
numbers that
number.
we are getting since the closure.
Since November through, here we are. Gotcha. 6, 7 months. Okay. Well, that's a lot. Thank you. No other questions? Thank you so much for being here.
Thank you for the invitation to speak.
Thank you for having us.
I think we're doing fair on time, so we'll go with back to on the schedule, Mike Mandel, Executive Vice President, Piedmont Healthcare. And Mr. Worthy.
Good afternoon, Mr. Chairman. I'm Thomas Worthy, Vice President of External Affairs for Piedmont Healthcare. We've put up a presentation that will outline Piedmont's role in the healthcare infrastructure that is really more specific to our company, but then outline some pressures and some challenges that I think are applicable to all healthcare companies represented not only in presenters today, but also in the audience. So with that, I'm going to turn it over to Mike Mandel, Executive Vice President of Piedmont, who runs our day-to-day operations.
Thank you, Thomas. Good morning, Chairman Watson and committee members. Thank you for the opportunity of having Piedmont here this morning to speak with you about infrastructure, healthcare infrastructure in Georgia. I'm going to start by giving a little history of Piedmont and where it came from and where we are today in that infrastructure. In 1905, Piedmont was founded right down the street, I think. In the 1950s, it moved to Peachtree. If you'll go to the next slide. By 2013, we were serving 5 communities, including the Southern Crescent and Jasper Ellijay up in the mountains. 2018, just 5 years ago, we had expanded that to include to the west and northwest, Covington, Conyers, Monroe, and Athens. And currently, fast forward to 2022, last year, we added Macon, Augusta, Gwinnett in Snellville, and Cartersville to the hospital portfolio. Hospitals, as you know, are not the only place care takes place. We try to make ourselves available, at least at some basic level of care, to all Georgians through the Piedmont virtual care that is accessible to citizens throughout the state. In addition, we are in Walgreens, in 25 Walgreens locations, about 70,000 visits a year to those locations, what we call Piedmont Quick Care. Urgent care, which was particularly important during the pandemic as people were shy about going to the ER and have remained so. We expanded greatly. We now have 68 urgent care locations throughout the state. We're seeing 1 million patients a year in the urgent care settings. Provides a lot of ER relief and puts care in the setting it belongs. From a primary care standpoint, we have over 200 primary care offices with 1.8 million visits a year to those primary care. In addition, 600 specialty care locations throughout the state, cardiology, vascular, heart, cancer, all the specialty offices that people need to go visit. About 1.6 million patients a year visit those clinics. This all adds up to about 1,000 locations throughout the state, serving about 4 million patients a year. So we're covering a large swath of the state. Size is one thing. We focus, frankly, first on quality, and there's an external agency that rates the hospitals, Leapfrog. Our last public scorecard, we had mostly A's, some B's, and a couple of C's. Our goal is to have every one of our facilities as an A. Our internal tracking has us there today. We'll see what the next public results show. This is really important because it not only is for the health of our patients and our citizens, but also results in lower cost. Higher the quality, the lower the cost. We've been named the safest system in Georgia the last several years running, and we take that very seriously, in addition to the next slide, which is what we face economically. So all that, we have all that infrastructure. We got through the pandemic through a partnership with the state and local communities, and now we're post-pandemic. And now we're facing a crisis ourselves in the economic arena as well. Across the country, health systems are losing hundreds of millions of dollars a year. Some of the largest systems throughout the country, and some of the most well-known, Mayo, for example, Geisinger, all the household names are losing hundreds of millions a year, several over $1 billion a year. Next slide. Why is that? Coming out of the pandemic, there was a lot of federal funds available for the pandemic care. Coming out of it, those funds are no longer there. However, we now face, the highest inflation that we've had in a very long time. Our contracts in all health systems contract with the insurers through multi-year contracts, and so those things get set 3 and 5 years. Several years ago, when inflation was 2% and 3%, we're still living under those. So we don't adjust our price when inflation goes to 8% and 9%. We have to make up for that through cost savings. If you go to the next slide, Thomas, you'll see the daunting challenge of contract labor. Pre-pandemic, this slide is really important, inflation we have, and then we have the staffing challenge all health systems face in the state. Pre-pandemic, the year prior to COVID, we spent $40 million in total, $40 million for the year in agency labor. The last year of the pandemic, 2022, we spent $400 million in agency labor.
Define agency, please.
Okay, so contract nurses, respiratory therapists, where we have to go out and procure, we can't employ them ourselves, and so to get them, we contract with an outside agency. Thank you. The cost increase associated with that contract labor was not the only additional cost. Our own employees, we had to adjust as well during that time. And if you look at the slide, this slide in particular, the box to the right, it's all health systems in the state face this. Our particular numbers, we've added over $650 million a year to labor expense in combination between contract labor and increases in our own employees' wages and salaries. How do we do that? We have to do that with cost cutting, frankly, but we'll get to that in a minute. In addition, during this time, we've seen a dramatic increase in costs in our charity care, bad debt, and self-pay. You can see over the last 10 years, we're spending about $100 million in these in support of charity care. Back in 2013, 10 years later, it's about $400 million. Again, not anywhere near kept up with through our contracts with payers. Well known, I think, hospitals lose money, or health systems lose money on virtually all payer types other than commercial contracts. So Medicare, Medicaid. In this slide, it shows the Medicare margin, roughly negative 10% overall. It's getting a little better with federal relief funds, but when that goes away, it's back up in about 10% range. Next slide will show you the other kinds of government payers. Medicaid, Piedmont specifically loses money on Medicaid, Medicare, TRICARE, self-pay, and then it all gets made up through the commercial contracts, which is about 35% of our patients. So 65% of our patients, we lose money on every patient, and it gets made up through the 35% with commercial pay. You make all that work through a relentless focus on stewardship. I think this slide is really important in that what we try to do is look at the case mix adjusted cost per patient. So break it down to a per unit cost. In 2013, our cost on a case mix adjusted basis, our cost was $7,157 per case mix adjusted admission. Pre-COVID, that's without inflation adjustment, we were below the level we were in 2013. We were at $7,030 per case mix adjusted admission. With inflation, fast forward to today, the pandemic has increased that cost from $7,000 to $8,200 per case mix adjusted admission for the reasons I've just cited. If you look at that compared to 13 on a inflation adjusted basis, we are still down a little less than $1,000 per case. So we're taking costs out of the delivery system every day, and that is the only way we have been able to remain fiscally responsible in face of these other factors that I've mentioned. So summarize, I guess, for Piedmont, we've tried to grow responsibly to serve the entire state, not just one community or two. We're the largest healthcare provider in the state, 1,000 locations, and one of the largest employers. That number up there is incorrect, 27,000. For the record, it should be corrected. We have 45,000 employees, and most communities that we are in, we are the largest employer in those communities, about $7 billion in revenue last year. Our focus is on quality and stewardship. And the economics of that scale and responsible growth have allowed us to navigate through these times. The pressures on the industry are not going away. The stability of the infrastructure is at risk. I think it noted almost half of the systems across the country are losing money, negative operating margins, and for the reasons we talked about, inflation, labor, skyrocketing wages, and top-line revenue not growing in proportion. The next slide, Thomas. In terms of our role and responsibility as a not-for-profit health system, last year we provided $355 million in community benefit, did 19 community health assessment need assessments, and implemented strategies to address those needs. From a tax standpoint, people often say, well, you're a not-for-profit system, you're getting tax relief. What are we getting back in exchange for providing property tax and sales tax relief? Our tax benefit last year was $167 million across the system. So we appreciate that and grateful for it. We try to make good use of it. For every dollar that we saved in taxes, we spent $2.13 in community benefit. So we had $167 million of tax benefit, and we provided $355 million in direct community benefit. And that's a very strict federally defined definition. It's not us making it up. Final thoughts for you all today. From our perspective, health systems, hospitals have been in the crosshairs from people across a variety of sectors, ranging from traditional press, academics, legislators across the country, range of criticisms. Most of the allegations tend to be one-offs and sensational, but it's important to note that behind only, I think, oil, coal, and power generation, healthcare is the most regulated industry other than those in the country. And that regulation provides an enormous amount of transparency into the practices, spending, and collecting that health systems do. This has ratcheted up significantly in the last several years. And we encourage and hope we're part of, as you do your work, educating and helping to answer any questions that you have so that any changes that are considered are done from a thoughtful, holistic measure and not kind of wholesale blanket changes. So thank you for your time again, and I'm happy to answer any questions.
Thank you so much. Vice Chair does. Question?
Yeah, thank you for your presentation. My question is, it looks like you guys have a few facilities on the south side, and then, of course, you've got the big hospital in Midtown. Have you guys given any serious consideration to becoming trauma centers at any of those locations, and where did you end up on that?
Yeah, it's a really good question. The first thing we've done is looking at and trying to understand where we've been affected. And frankly, surprisingly, Henry County is one of the most affected ERs. It's frankly our you would be surprised, of all the hospitals, Henry County, Piedmont Henry is the largest volume of ER in our system. It's gone up dramatically. The trauma is significant. Now they used to drive by and maybe go to the city. They don't do that anymore. So our first action has been in Henry County. We've recently received certification to move to a level 3 trauma center, hired neurosurgeons 24/7. So that's our first focus. We are in Athens and Columbus, in the core of the city. We think the Henry County will be the most important thing we can do right now. to relieve the trauma coming north, and then we'll go from there once we understand the effects elsewhere.
Thank you. Senator Lucas.
Question for you. What do you figure your bottom line would be if this state went to Medicaid expansion? Don't tell me y'all hadn't thought about it.
Pardon, don't tell me I haven't thought about it. Don't tell me I haven't thought about it. I hadn't thought about it recently. No, I'm just kidding. I'm kidding. Frankly, we have thought about it, and we do have, I think, some estimates, but I would rather confirm that back in the office and get back to you today, if that'd be all right.
Why is everybody scared?
I'm not scared.
This state has made a policy position not to you go into Medicaid expansion. I know all of you have looked at what your numbers would be, the people you serve, what you write off. Why you can't give me an estimated figure?
Yeah, sure. Well, I can tell you we'd be better off.
You
All right,
did it in a roundabout way, didn't you?
Let me ask a question. So you discussed how with the closure of AMC, that affected you from a trauma level standpoint, especially Henry County. Are there any other effects relating to the closure? Or?
Well, the ER, frankly, the ER visits in multiple of our ERs, obviously Piedmont, Atlanta, in Buckhead has seen the largest direct increase in volumes. It's doubled. The volumes have doubled in the Atlanta ER since the closure. And then we see it down, frankly, all the way down to Fayette County.
And that's, so mainly through emergency room, and emergency room, therefore.
Mainly through the ER.
Gotcha.
Yeah.
Gotcha. Okay. All right. Got a couple questions here, Chairman Hostetler.
All right, now I've actually got a couple. First one may be kind of quick, but I'm Mike 8. The self-pay, I know it used to be that the only people that were charged self-pay were the people who didn't pay, and so it didn't matter what the charge is. But what is your discount right now on self-pay
Do you know the answer?
compared to, say, Medicaid or?
Yeah, let me get back to you on it just to make sure it's current.
Okay, and then another question would be the labor shortages. It seemed like they started creeping up, and then other ways it seems like it happened all at once. But it's not just the shortages, it's the fact that crews aren't together anymore. They're all getting split up, and you don't have a cohesive team anymore. Where do you see this headed right now?
Yeah, that's a really great question, and it's interesting because that team approach not only affects the floors, but we see it playing out dramatically in the operating rooms where, you know, there's really been a team environment historically, and those are all fragmented. You know, we think about this 20 hours a day at least, probably. Where is it headed? I think it's beginning to get a little better in that the people who migrated to contract labor have begun to migrate back slow. I think that'll continue slowly. I think that they're also finding grass isn't always greener on the other side, and so, you know, I think there'll be a natural migration settling back to permanent employment. The reality is the supply is not going to be sufficient regardless because there's a shortage, and that shortage has grown. We are trying to infuse that with programs to support students going to school for allied health and nursing, and we're working now very deliberately with all the community and technical colleges throughout the state to try to increase the supply. So, to, you know, specifically, I think the migration out to contract will settle down. I think we've lost permanently a portion of the workforce who burnt out during pandemic and is of age and means that they don't need to return. And it's going to be a long haul to try to get that back. The best thing we can all do, I think, is encourage students out of high school and college to get into the allied health professions and provide support for it. That's the long-term solution.
Okay, and if I could, one more quick, because these guys do a lot of things right, so I want to catch them while they're here. But when you look at all these facilities, you've got at different levels. I know you guys moved up in our area with the hospital in Carswell, but the urgent care is in Rome and all like that. When you look at all of them, where do you see that has the most impact on the healthcare outcomes of a person, of an individual?
So I want to make sure I get the question right. The impact of what?
Of your urgent cares, of your quick clinics.
Oh.
You got your family practice.
Yeah. Frankly, I think about it as in two categories. The most important thing is, aside from the very acute episodic stroke, heart attack, things like that, the most important thing is to provide venues for maintenance and preventative care. And that's where, these various venues of primary care in particular, I think primary care is probably the most important asset in the ecosystem of healthcare, because, and then we got to get people to go and try to anticipate health needs and have behaviors that prevent the episodic and more severe and costly events. So primary care and those care settings, I think, are most important.
So as you said earlier, improved quality, lower price.
Yeah.
Right, that's part of it, absolutely. We've concentrated on the right side of the table. In my head, it's not been turned, so we got two over here, and Senator Walker, Chairman, has not gotten to ask a question, so he's going to be first in line.
Thank you, Mr. Chairman. You talked about the workforce shortages and the challenges, and we hear that in every industry, every sector of our economy, but it's particularly acute with in the healthcare industry.
Right.
And you've enumerated some of the challenges with the staffing and the contract staffing, et cetera. And, but I'm curious, with the closure of the WellStar hospitals, surely you've been able to pick up some good folks that were formerly at those hospitals and hire them, and I would just wondered how that has gone and if that's helped some.
I'll defer to my colleagues from WellStar for the specifics. Here's my observation. That was what people would have assumed, but if you think about the percentage of employees that are contract labor in the healthcare settings today, some of those, I assume there was a significant amount of contract labor in those facilities. Those people probably, people were all offered jobs, as I understood it, at WellStar, and many of them went there, probably most of the permanent employees. The others, contractors, will go anywhere, whether it's in the state or out of the state. There wasn't a whole lot in the being absorbed elsewhere, frankly.
Were you able to hire any physicians? Or
We did hire some of the physicians. We had several of the physicians that outreached to us to try to maintain the clinic that they had in the community, and we had applications of physicians into the Piedmont Clinic, and several practices are now part of the Piedmont Clinic.
Okay, thank you.
Senator Brass.
Thank you, Mr. Chairman. Thank you, Mike, for being here, and Thomas, thank you for being here. Is there, if Piedmont decided, let's say today, and I'm not asking you to, and I'm not putting you on the spot,
Sure.
but just hypothetically, if y'all decided today that you wanted to go fill the void in this new healthcare desert that's been created in South Fulton, you wanted to go build a hospital, you're going to break ground tomorrow. Is there anything government-wise that would be in the way of stopping that, and trying to figure out what can we do as a state government to help attract people there?
It's a really good question. Frankly, I like to think I need to just get out of the way. I do think we are helping to serve that because of our presence on the south side. There's been a lot of migration. It's not as convenient, but a lot of migration south, as you know.
Piedmont Union was number one on your chart. Thank you.
Right. Been a lot of impact down there, but so we're serving the south side well. I think probably the need is there, so that's not going to be a hurdle. Probably economic incentive.
Mm-hmm. Okay, that's the only thing? So like, if y'all want to break ground tomorrow on a hospital, we said. we're
Not
gonna-
us, I'm saying.
Well, just anybody.
Anybody.
Anybody want to break ground tomorrow, they could do that.
I think the
if they could make
regulatory
it.
hurdles would not be the burden. I think it
Okay.
would be an economic incentive issue.
Okay.
Thank you. Senator Jackson.
Thank you, Mr. Chairman. I just have a question about how you all choose your locations for urgent care clinics. So your map here, it's a little small, but it does still seem that the vast majority of urgent care clinics in metro area are located north of 20. And so can you all speak to the process that you go about to deciding where urgent clinic locations are, and how might we focus more in the south side of our great county?
So first, it's we look at where our patients are, frankly, where the patients are coming from, and try to serve those communities and those patient locations. So again, making it convenient, close to home. We do have we have opening up. You want to address the ones that are opening? I know. Go ahead.
And Senator, just in next week, we will be part of the Summer Hill development right down the street. We will be participating in a groundbreaking for not only a big urgent care facility there, but also primary care. And it's pretty neat because that's be a few blocks away from the original Piedmont Sanatorium, which was on the first slide, which was right down the street on Capitol Ave.
Any other questions? Senator O'Rourke.
Thank you, Mr. Chair. And I have a long affiliation with Piedmont, having had both my children there and had wonderful care. We have a statewide trauma commission, on trauma care commission, and this whole goal of expanding the Tier 1 trauma care. And it would seem with Piedmont's resources, I'd love to know what you all have done in that regard, because when Tenet owned this chain of hospitals that Wellstar bought, they worked diligently, served on the commission, on the statewide trauma commission, and turned that AMC over there, Old Georgia Baptist, into a level Tier 1 trauma care. So
Yeah,
love to hear
Yeah,
your.
sure. So, in Columbus, we're the regional coordinating facility and take care of trauma in that part of the state, as well as Alabama. Whenever there's a mass shooting, the Columbus facility is a state coordinating center and deals with a ton of trauma. Same as in Athens. And then we, as I mentioned, Henry, and we have another facility, I'm not going to say which now, moving up its level in trauma care. We're doing it where we can, and we've got to continue to look at it and see what the needs are, and we will make the investments as the community needs them.
They're needed. Thank you. Thank you, Mr. Chair.
Thank you, Senator O'Rourke. All right, can't say we haven't been gracious with our time, but we're actually a little ahead of schedule. Thank you very much.
Yeah, I appreciate your time.
Appreciate that. And so we're doing well with time. Thank you so much. We are CEO Michael Thurman and Dr. Sandra Ford, DeKalb County. Thank you so much for being here. Welcome back.
Good morning, Mr. Chairman. And each time I come and walk in the Gold Dome, I have warm feelings for having served here with two former colleagues to my left, but then not so warm when I realized that at least two members on the commission I served with their parents. So on this committee, so that doesn't make me feel that well. But thank you so much, Mr. Chairman, for your leadership. Thank you so much for the committee's leadership, for the work that you're doing on behalf of the people of this state. Because the issue regarding the healthcare infrastructure, some issues have already been dealt with. And obviously there are some challenges in South Fulton County, but there are also challenges associated with South DeKalb County. because AMC served a significant number of DeKalb County residents, not just in the trauma care level, but in a broad range of services, primary as well. So the closure of AMC also impacted DeKalb County. So what we did, and I'm delighted that Bryce Gartland is here, Dr. Gartland from Emory. We recognize that whatever the solutions are, they're going to be long-term solutions. And we had to move quickly because as the two hospitals closed in South Fulton, we were concerned about Hillendale in South DeKalb, who also serves a large percentage of uninsured residents in our county. I'm proud that we were able to reach out to Emory leaders and began to do something we had not done historically in our county. DeKalb County and Fulton co-own Grady Hospital. From inception, it has been an investment that DeKalb and Fulton has made. We're very proud of that relationship, and each year, this past year, annually, we invest some $20+ million along with our Fulton County partners in Grady Hospital. Because of some challenges faced because of the pandemic, we increased that investment by an additional $8 million. So this past year, we invested some $28 million in Grady. That's something we've done historically. That's something we will continue to do because not just Atlanta, but Metro Atlanta can't live without Grady. But what we did differently, primarily because of the challenge that AMC presented, was that we had to protect the assets and resources that we had. And Hillendale, and to a lesser extent even Decatur Emory, are two critical healthcare facilities that had to be protected. Number one, we invested some $12 million in Emory Hillendale Hospital as well for the first time in local dollars. We invested $4.7 million to expand the hospital's waiting room by 15 emergency room bays. We invested $4.5 million to renovate the hospital's second floor intensive care unit, $1.7 million to replace an outdated CT scanner. We also invested $2 million in our community service board because one of the realities of COVID, we obviously track very closely the people who unfortunately become infected, some sicken, others unfortunately die. But mental health is a growing COVID-related crisis all across this state, all across this nation. We also invested $250,000 to a nonprofit entity that will inform and encourage eligible uninsured residents to register for the Affordable Care Act, Medicaid, and other subsidized insurance programs. The reality is that there are tens of thousands of DeKalb County residents, Georgia residents who are eligible for government-sponsored insurance programs but not registered. One of the things I think one of the best investments we can make is to invest in ensuring that people who are qualified are actually enrolled in the various programs. The last thing is this. We mourn the loss of trauma of level 1 trauma beds. We recognize that we must do more than what exists today and that Grady is the only one still standing. But the reality is, my fellow public servants, is that we'll never have enough money to invest and finance trauma beds if we don't begin to intervene and reduce the number of gun-related deaths and injuries in our state. Now, this is not a statement about the Second Amendment, but it is the reality that the number one cause of injury and death among young people, particularly young people of color, are death and injury associated with guns. There was a report just this past week of an unfortunate shooting. It was in Atlanta, but it could have been in DeKalb. It could have been anywhere in any urban or rural, quite frankly. One young lady lost her life, another young man was injured. What was not reported is that scores of young people were also traumatized by a violent event. Studies show that those who are not just injured, but those who witness violence are more likely to either become victims or victimizers of violence. So I say that to say that we have also invested nearly $2 million in the first ever Hillendale Trauma Recovery Center. It is a hospital-based violent prevention program that will employ 10 specialists, including psychologists, outreach workers, and behavioral health specialists. The point is, so much is to be done. These are complex issues, politically charged. But one of the things that COVID taught me is that the politics doesn't matter as much as the lives that we can save. So what is at risk today is not politics, but how many lives can we save? How many families can we hold together? To conclude my remarks, I've asked Dr. Sandra Ford, who served as the health director in DeKalb for 2 decades and also for Fulton. She served at the state level. And most recently, she was a special assistant to the President of the United States in public health. She worked in the White House. And because I needed help, and she was gracious enough now to serve as a consultant to the CEO of DeKalb to help us manage and understand and seek solutions to these difficult problems. We can curse the darkness or we can light a candle. What we seek to do in DeKalb is light a candle while we seek to solve the more critical problems. So, Dr. Ford, there's a ask, Mr. Chairman, if you will, and it will be short, just 3 minutes.
Thank you, Mr. CEO. Always a tough act to follow. Thank you for your time today. In March of 2020, a federal public health emergency was enacted in response to the COVID pandemic. Certain flexibilities were created as a result of that public health emergency. For the purpose of this conversation, that most important topic was Medicaid continuous enrollment. Every year, folks have to re-enroll for Medicaid. That requirement was relaxed in order to ensure that folks did not lose coverage during the pandemic. That resulted in a 20 million increase nationally in Medicaid enrollees. In March of this year, March 31st, that public health emergency was terminated. We are at risk nationally of between 5 and 17 million individuals losing coverage. That includes 5 million children and 12 million adults. Kaiser Family Foundation did a study of different states and estimated about an 18% Medicaid enrollment rate across the nation. If that were true for Georgia, based on that population, we would have about 2 million plus Medicaid enrollees in the state. With this public health unwinding, that means that nearly 400,000 Georgians could be at risk for losing their coverage. Georgia's current plan for addressing the Medicaid re-enrollment includes data matching for address verification through mail contact, USPS, and email. They do not have their plan to include phone or text, as is taking place in other states. Our ask in DeKalb County is to partner for an increased awareness and education campaign and an enrollment campaign. This issue is directly tied to the issues we've been talking about all morning, because these uninsured folks are the same folks that are going to show up in the hospitals that are already overburdened. And so we are asking for assistance in having a more aggressive state and local action to ensure that enrollees are even aware of this, that we do better than just mail and email. Everyone does not speak English in this state. Everyone does not have access to email. And so we need to have other opportunities to enroll individuals and ensure that we don't deprive coverage of those who are eligible. Thank you for your time.
Thank you so much. I appreciate that. They have been working on the unwinding prior to the unwinding, and that is so the Department of Public Health, I would certainly ask you to reach out to the executive branch, Department of Public Health, and DCH, Department of Community Health, which administer that, and insurance. And, well, which is under the Department of Community Health. So that is, part of that is actually being done. So just reach out and ask, and they will be able to make those if they need to add more, and if that's a good idea, and that will reach out more people. Because I agree with you. As I started out the discussion, I don't think you may have been here, but you're correct. If we have what's estimated to be over 2.5 million people that are still on Medicaid rolls, that will be unwound over a longer period than 6 months. At the same time, we're coming on board with our Medicaid waiver, which is 100% up to 137%. So basically, anybody at 100% federal poverty level up to 400% federal poverty level will be on the exchange in the state of Georgia. Of course, you have to sign up, and that's what CEO Thurman discussed. You do have to sign up, and those at 100% or below will be on Medicaid expansion. If you have a part-time job of 20 hours a week, or if you do 20 hours of volunteer work at approved sites, or if you go to vocational rehab or vocational technical school, or if you go to college. And certainly if you're not able to do any of those, then you should be applying for disability, which is a federal program, don't have control over. I know it's onerous at times, but it does work. I would encourage you to reach out. Thank you very much for bringing that and reinforcing that information. Any questions for them? My vice chair.
Yeah, thank you very much for your presentation, and I would just like to remind the chairman that Commissioner Broche doesn't work for DCH, they're a separate department, and those two departments are working together on the redeterminations and unwinding. So, but my question is, and really I just wanted to point out that we have a number in the desert area that's been identified of federally qualified health centers. And we haven't really talked about that today. I forgot to bring it up when Fulton County spoke, but there are a bunch of federally qualified health centers in the metro area, including the South Side and also in DeKalb. And I just wondered if you guys are working with them to kind of address the big picture.
Oh, absolutely. MedCura is one, formerly Oakhurst. We work with them to do vaccinations and testing throughout the pandemic, and we'll continue to do it. We've invested in the health center in Clarkston that serves primarily our immigrant population. I think we just made a $250,000 appropriation to them. One of the things that I'm most excited about that Dr. Ford is helping us with is resource mapping. Because sometimes we just don't know. I don't know exactly where all the services are. I think someone commented that there were no urgent care, very few below I-20 emergency rooms. Mm-hmm. So what we have to do at the local level is to resource map to see exactly what's available, when it's available, and where the gaps are, and then seek state and local and federal funding to help fill those gaps. And I think it's something we could do statewide if we could just communities working together.
Thank you. I just wanted to make the point that there are other resources that take all comers, and I want to be sure they're included in the conversation.
Yes, ma'am.
Senator Jackson.
Thank you, Mr. Chairman. And thank you, Mr. CEO. So we've had this long-standing partnership from since the beginning with Grady to ensure that DeKalb County had Trauma One. Is there any interest in the county if we were to create another Trauma One providing hospital on the southern side, on the south side of DeKalb or Fulton, quite frankly? Would there be interest in the county entering into another partnership to make sure that we have another Trauma One level hospital available to the great citizens of DeKalb County?
Yes, Senator, absolutely. And the investment with our partners at Emory suggested it's not just words, but we recognize that we can't allow Metro Atlanta to lose another hospital. And we talk about Emory and Hillendale, it serves Rockdale and Newton as well. It's not just the DeKalb County residents. And I know Mr. Gartland is going to speak to it. I don't want to steal his thunder. Where is he? Raise your hand, Doc. He's over there. He know we serve East Metro. And so we need, if we could get something on that side of Metro Atlanta, especially with Rivian and other things being built a little bit further down the road, we need more health care on that side of Metro Atlanta.
All right, I think we've exhausted. No, we have Senator Orrock.
Thank you, Commissioner. That's Chairman. Mr. Chairman, wonderful to have you with us, Mr. CEO, and as well as Dr. Ford. I've seen estimates that around 500,000 Georgians will lose their Medicaid coverage in this wind down and recertification, and I really appreciate the very practical suggestions that we fund a much more expansive outreach. What would it do to have 500,000 Georgians knocked off of Medicaid?
Dr. Ford? I'll defer to my expert.
Well, the most obvious response is that it will overburden your emergency rooms that are already overburdened, number one. Number two, it worsens health outcomes because now you have folks that are having chronic diseases that are not being addressed. I could go on, even your community violence to some extent, because everything is connected. And so when you talk about social determinants of health and health care, they're all interrelated. So lack of insurance contributes to your behavioral health issues, et cetera. It's just a bad look overall.
And is there any role that counties can play and cities can play in the face of the fact that the state agencies already said their employees are overburdened in doing this? I mean, that's in the headlines in the Atlanta paper. That's not me speaking. That's what their department is reporting.
Well, local governments, jurisdictions, you got to get a health care agenda. And my understanding, my heart is right, but my knowledge is limited. We have to turn to experts like Dr. Ford to help us create strategies and direct funding so we can be more successful in leveraging the resources that we have. Working with the state, the governor did appropriate $165 million that went to Grady as a result of some funding challenges during the recession. We just have to work closer together because these are all of our citizens being impacted.
And we did fund that in the budget, the unwinding process. You're absolutely correct. I mean, in Senator, you're correct. I mean, if you don't have insurance, you're not getting primary care. You're not getting plugged in. You're not getting your diabetes or your mental health issues addressed, and you are showing up in the emergency room. So it is important to get those enrolled and continue to. It's not going to be just a one-time thing. So thank you for your question. Thank you. Any other questions from the committee? None. Thank you. So thanks so much for coming.
Thank
Appreciate
you, Senator.
that.
Thank you.
We are at CEO President Candace Saunders and Jim Budzinski, Wellstar Health System. Thank you all for being here.
Good morning, and thank you, Mr. Chairman, and members of the committee for organizing today's meeting and inviting Wellstar to participate. I also want to thank you for your ongoing work and commitment to improving our state's healthcare infrastructure. As you do this important work, we ask for your help on important issues that confront all of us who provide health care in Georgia, from tort reform to the expansion of access to coverage, to adequate funding, to addressing the unintended consequences of surprise billing reform, and ensuring our communities have sustainable care models. There are many important issues we need to work together to solve, because none of us can do it alone. As Georgia's largest provider of charity and uncompensated care, serving nearly 1 in 6 Georgians annually. WellStar sees the access, the affordability, and quality of healthcare in our state as a vital part of our mission as we look forward to working with all of you in the future. I'd like to take a few moments, though, to share with you a little bit more about WellStar. WellStar has deep-rooted community heritage that serves as a foundation for how we care for our communities and has shaped who we are today. Our hospitals came from hospital authorities and local roots, and our board is a voluntary board with representatives from the community. And we have community boards as well as our overall WellStar Health System board. We provide care for the entire family through our 9 hospitals, 5 health parks, 9 cancer centers, 18 urgent care facilities, 80 rehabilitation centers, as well as our nursing homes, hospice, home care services, and our over 300 medical office locations across the state. Most importantly to me, as President and CEO, are the over 24,000 team members working hand in hand with over 3,500 physicians who make up our WellStar Clinical Partners, which is our clinically integrated network, who come to work every day ready to serve our fellow Georgians. Whether at Kennestone or Cobb hospitals, which were recently recognized in the top 25 hospitals nationwide, and our top 2 hospitals in our state for the amount of charity care they provide. Or WellStar Paulding, which was the first hospital in Georgia to be recognized with the Malcolm Baldrige Award, the gold standard for performance excellence and quality, both inside and outside of healthcare. Our mission remains the same: to enhance the health and well-being of every person we serve. Our hospitals also play a role as one of the largest trauma networks in the Southeast. Both Kennestone and WellStar North Fulton serve as Level 2 trauma centers. And with the recent growth of GME at Kennestone, it will likely become a Level 1 in the near future. We have additional trauma designations at Cobb, Paulding, West Georgia, and Spalding Hospital. We have a significant commitment to trauma in the state of Georgia. We are proud to be home to the largest Joint Commission certified stroke network that serves the Northwest and Northeast Georgia, the largest structural heart program in Georgia, and also our WellStar Stat Clinic for lung cancer is a national model in lung cancer diagnosis and treatment. We also have some of the fastest growing programs serving our community in robotic surgery and other important care models. As home to the first CyberKnife cancer treatment site in Georgia, we're proud to be on the cutting edge of innovation in healthcare, from neuro and stroke care, cardiovascular care, pediatrics, and also on digital health. You've heard here today the importance role of digital in the care delivery. The initiatives of Catalyst by WellStar, which partners with other companies, many which are small and Georgia-based, and are based on to improve patient care, but also addressing the social determinants of health. We firmly believe that these solutions will enable enhanced access and cost-effective care across the state, and we have to start somewhere. From small towns to big cities, we see opportunities for technology to positively impact health outcomes and the state of healthcare across Georgia. We see a different future for healthcare, one that's focused more on prevention, chronic care, risk reduction, and less on sick care through our emergency departments. Wellstar has a long-standing commitment to training our healthcare workforce through over 400 partnerships with our schools, with our community and technical colleges, as well as our universities. We're also expanding and investing in robust efforts to educate the next generation of healthcare providers. Examples include our graduate medical education programs, our nursing school at Kennesaw State University, and our newly formed partnership with Georgia State University to grow their respiratory therapy program to help with the shortage of these vital professionals that became very, very clear during the pandemic. The care of our team members and physicians extends beyond the walls of our Wellstar facilities, directly into our community through unique partnerships and collaboration with our community partners, delivered through our Wellstar Center for Health Equity. We have many, many examples, and also have given you a handout that includes some of them. There also seems to be a misconception about the markets we serve and our role in those markets. Each of our founding hospitals and several of our new hospitals serve as a safety net provider for the area they serve. And many of these markets, rural, community, urban, we are the sole provider of all healthcare access. Of the over $1.2 billion of community benefit we provided last year, more than $1 billion alone was outside of the AMC markets. As a not-for-profit family health system, our facilities provide care for the entire community, regardless of their ability to pay. We care for all. At Wellstar, we have a deep and long-standing dedication to serving diverse communities, those in need, and underserved Georgians. It is who we are, not just as a health system, but as fellow Georgians. We take pride in our role as a vital part of our state's healthcare infrastructure. And I wanted to make sure the members of this committee and others serving in this building know that we are committed to working with you to find solutions to the issues we face as a state and as an industry. And as you are all well aware, and we've heard today, Wellstar has been no stranger to the unique challenges present in today's healthcare delivery. Perhaps no single event represents the complex, difficult environment we all face more than the closure of Atlanta Medical Center late last year. I've asked Jim Buzinski, our Chief Financial Officer, to be with me today, and he'll speak a little bit more about the financials behind that decision. But first, I wanted you to hear directly from me today about this issue in this decision as President and CEO of Wellstar Health System. Let me first say that it is not the outcome we wanted, nor is it a decision we made lightly or abruptly. I understand and empathize deeply with the sense of loss many still feel, and fully realize that AMC's closure presents a challenge for the Metro Atlanta region as a whole, and specifically the members of the local community who receive care at the facility. There is still grieving going on within our own system and with the AMC team members and physicians and our patients, and we are continuing to support them as they move on into their new roles. As we have said publicly many times since the closure was announced, the closure was a direct result of a series of financial obstacles and realities that were impossible for Wellstar to overcome alone. From dramatically aging infrastructure, low patient volume and bed utilization, a very challenging physician model, lack of public funding for a safety net facility, a very reactive care model where the majority of patients coming into the hospital came through the emergency department, to the skyrocketing labor cost that you heard about today that were no longer mitigated by emergency pandemic aid. The list of the critical challenges at AMC for us was insurmountable without a partner. We invested more than $350 million in AMC over 6 years, including the purchase, financing critical capital improvements, and funding the sustained operating losses, which is more than 3 times the annual investment in AMC compared to the historical averages. Given these challenges, we announced a public search for a sustainable future through a partnership or sale. We discussed the issues openly with staff, with the community, and with our elected officials and other stakeholders. Our search was exhaustive. We spoke to local, regional, and national systems, nonprofit and for-profit. And unfortunately, our efforts were not successful, given these financial realities moving forward. I believe the challenges we faced at AMC are ultimately why we were unable to find a partner, because each of them reached the same conclusion we did. AMC's trajectory was not sustainable and would likely only grow worse with time. No one saw a sustainable economic model to continue to provide inpatient hospital services. To continue operating AMC, Wellstar would have had to risk the financial health of our other facilities and access in the communities we serve, who provide critical safety net care in their own communities. We did not believe it was right or sustainable to do so. For example, we have been, suggested, and it has been stated that all we did was throw our hands up and call it quits. But we'd like to say that we continue to work with the community. We continue to provide service, And one example of that, and there are many, was we recognized that the patients seeking care at AMC South and East Point were needing access to primary and chronic care services. We invested $5 million in a partnership with Southside Medical Center, a federally qualified health center, to expand its size and capacity to offer primary care, behavioral health, dental health, and more. This is only one example, and we continue to work with the Southside Medical Center, as well as those other primary and chronic care centers who provide much more holistic health care than we could ever provide in an emergency department in an episodic way. But I think it's so important, as I listen today, we have to help ensure our communities have access to the right care at the right time, focused on addressing the social determinants of health, as well as their physical and mental health needs. Today, we do not have a plan for either of the AMC campuses, and I've been in many, many conversations. But we're committed to a thoughtful process to determine the best use for the future. Our priority was a safe transition of care for patients and ensuring our team members were placed in jobs at other WellStar facilities or at other health systems in Metro Atlanta. We look forward to engaging with the community about the future opportunities, and we have daily conversations with different ideas and suggestions. In closing, the decision regarding AMC was very, very difficult, and I would hope none of you are put in that position to make that very difficult decision. It came after much deliberation and a relentless effort to find a sustainable solution, and I really cannot emphasize enough, it needs to be a sustainable solution. Following the announcement, we have been open, honest, and transparent about the challenges we faced and the reasons why we arrived at the decision. And I wanted to make sure that WellStar was present here today to not only answer your questions about AMC, as well as the other work that we do across the state. But also assure each of you that we want to be part of the solution to these challenges, just like we have been a vital part of healthcare in the state for many generations. We're also here today to ask for your strength and partnership to help solve the issues that confront our healthcare infrastructure in Georgia. We need your help. We need adequate resources to meet the needs of Georgians. We need expansion of access to coverage. We need tort reform, and we also need help on workforce issues. The list goes on, but we're committed to be part of the solution and be an active partner. And as we look ahead, whether it is our future partnership with Augusta University Health System, the next innovation developed by one of our team members, or the life-changing work of our community partnerships, WellStar is excited about creating a healthcare that is a healthier future for all Georgians and the opportunities we have to fulfill our vision of providing world-class health care to more Georgians each and every time they need health care. I would like now to ask Jim Buzinski to run through some of the financial numbers, if I may, Mr. Chairman.
All right. We go on 20 minutes, but if you don't mind being brief, we had allotted 15 minutes for everybody. So why don't you step up and why don't we get the CFO on board, and then we'll ask questions. And thank you.
Thank you, Candace. Thank you, Mr. Chairman, for inviting us here today this morning. We appreciate that. Members of this committee, we thank you as well for this opportunity. As Candace mentioned, my name is Jim Budzinski. I'm the Chief Financial Officer of the WellStar Health System. I've been with WellStar now going on 15 years and work with my colleague and one of my best friends, Candace Saunders, for that period of time. What I'm going to do here is try to give you a brief, and I heard you brief, Mr. Chairman. It's difficult to be brief on such a weighty subject, but I'm going to give you a brief overview of some of the financial hurdles that are facing the healthcare industry that our colleagues from Piedmont Healthcare did outline, but also specifically to provide a context for the AMC closure decision. As our Piedmont colleagues noted earlier today, simply put, provider healthcare systems are confronting a unique set of challenges that are jeopardizing our ability to care for so many Georgians and Americans and the care that they need. From inflation and labor shortages to supply chain issues to constrained reimbursement to the end of the CARES Act funding, these obstacles we face are multifaceted, complex, and not easy to solve. You saw the headlines that our Piedmont colleagues put on the screen. Those are real. Specifically, with respect to hospital margins throughout the country, a recent financial consultants report by the firm Kaufman Hall said that on average throughout the country, hospital operating margins are now at 0 on average. More specifically, this is being collaborated by organizations who are experts in finance and experts in the healthcare industry, bond rating agencies. And I'd just like to share with you one of their recent reports. One organization, for example, the Fitch organization, said, and I quote in their recent report, this is a quote, "Over the last 3 years, not-for-profit hospitals and health systems have endured multiple disruptions caused by the coronavirus pandemic, and now by labor shortages, intense wage pressure, generationally elevated inflation. While volumes have rebounded from early pandemic lows, expense inflation remains pronounced, particularly for labor. And as inflation is expected to attenuate, eventually labor expenses appear to have been reset at a permanently high level." The only other thing I would say from the Fitch report from August of 2022 is they said, and this is a quote, that the core drivers for this sector will remain challenged for fiscal 23 and beyond. And they said, in referring to the financial health of the healthcare industry, that it is deteriorating. S&P and Moody's have said similar things. These challenges are also present in Georgia. Regarding WellStar specifically, in the last fiscal year prior to the pandemic, the WellStar fiscal year ending June 30th, 2019, WellStar did report an operating margin of 5.2%. This is consistent with our long-term goal of saving 4 to 5 pennies out of every dollar we receive for the purposes of accumulating funds, savings, for us to reinvest in capital projects for the future to meet the growing needs of the communities we serve. These results did include, pre-pandemic, the financial results of the Atlanta Medical Center's 2 campuses, which was a loss at the time of $16.2 million. WellStar's fiscal 2020 budget anticipated similar results for our health system and AMC. That budget was put together in May of 2019. Of course, that was before the pandemic, and it did not include any assumptions with respect to the pandemic. But even at that time, it was becoming clear that the ability to have a financially sustainable model for the AMC was not probable, as the AMC did not serve the entire community. The AMC model of care was reactionary, as Candace mentioned, when a more community-based, proactive primary care model was necessary. Further, it became clear at that time that both facilities, Main and South, were going to require substantial capital outlays to upgrade, or in case of the main campus, replace the current hospital. The replacement hospital at the main campus was estimated to be in excess of $650 million. These factors led to WellStar's February 2020 public announcement that a long-term sustainable solution for AMC would require a substantial additional investment that WellStar could not fund alone, and that we were going to seek potential partnering organizations to submit proposals to find a long-term sustainable solution for the AMC. Shortly after that announcement in February 2020, the country was hit by the pandemic, and in Georgia as well, and immediately financial losses went to levels never seen before.
Mr. Brzezinski, I get it, and, you know, gave your CEO the leeway of, 20 minutes, and you've been going now for another few minutes. If we can just, you're the CFO, you got the numbers, we're up to 2020, we still got 21, 22, and 23, so if we could make it, just, if you don't mind, just helping us out here. Thank you.
Yes, sir. Thank you. With respect to fiscal 21 and fiscal 22, the financial losses in the Atlanta Medical Center grew significantly, $50 to $60 million before any CARES Act provider relief funding. AMC was the beneficiary of that, and that brought operating losses down to a $20 million level for fiscal 21, fiscal 20 and fiscal 21. Here's the catch. The CARES Act funding evaporated in fiscal 22. It's done. It's history. It was one time only. And the increasing cost pressures of everything we've been discussing here caused AMC expenses to go up $40 million and caused revenue continue to decline, creating a $109 million operating loss in fiscal 22. And this combined with the staggering cost of building replacement facilities caused us to make our decision.
I appreciate you wrapping it up. Well, the MCG aspect of that, I mean, Grady and MCG, Augusta University, I mean, they're the ones who do the lion's share of indigent care in the state of Georgia. I mean, they were the ones who benefited the most from DPP. Is that not the same that Atlanta Medical Center would do also? I mean, you're saying the losses there. I mean, that's part of the reason the state worked with you. Because of your management, your skills in management and taking over Talmadge and those responsibilities.
Yeah, that's
compare
a very
and contrast.
First of all, I will compare and contrast. You might recall the Piedmont slide that was on the screen. It had a 65%, 35% ratio. 65% government patient care and uninsured care, 35% commercial care. That was their ratio. And you saw that screen that the 35% commercial patients paid for the financial investment and losses of the other 65%. I'm bringing this to your attention because the Atlanta Medical Center's commercial payer mix was less than half of Piedmont. Less than half. So that would mean 82% was public or uninsured, and only 18% was, in fact, commercial. With respect to Augusta University Health System, it is more consistent with a 70% public program and uninsured and 30% commercial. So there's a different DNA.
Different DNA that have been losing money for decades. Your management style skills should be able to turn that around for your...
We believe that the investment we can make in that organization through systems, processes, and technology can help improve its cost efficiency. And we ultimately believe that through those initiatives, AUHS and Medical College of Georgia will, in fact, benefit.
Good, thank you. Questions? Okay, Vice Chair.
Yeah, this one's actually for CEO Saunders, and it has to do with after the closure of the two hospitals, many of the physicians migrated to other WellStar facilities, and many of them did not. I wanted to know what the status is of the non-compete agreements that were in place and whether those are being enforced.
Yeah, again, as we worked with the physicians, we approached it in a very individualized way, and so we allowed those physicians to pursue other opportunities and did not hold them to their non-competes.
Senator Jackson.
Yes, thank you, Mr. Chairman. CEO, can you talk a bit about what type of specific work was done to ensure that AMC patients were had some continuum of care? So my experience, I work with people who are experiencing homelessness. When we shut down a camp, we make sure that they have access to care. So can you talk in detail about that process to make sure that every AMC patient had some type of continued care?
As we made the difficult decision, we already had information about where our patients' homes were, also our team members, and we'd already done all that analysis in the months leading up. And so we have our case management, our social work groups, working directly with the physicians. And with our patients, we began the transition to outpatient federally qualified health centers. We worked with Mercy. We worked with other resources. I heard CEO Thurman talk about we had to look at all of those services and all the access. In addition, as you know so well, the social services that many of our patients needed. And in addition to those case management and those efforts with social workers, we also engaged with the different community centers, the churches, neighborhoods, as well as with the mayors, because we have multiple mayors that we work with, on a communication plan and ensuring that they knew where ERs were, they knew where the different outpatient services were, they knew where other healthcare services were available, including the federally qualified health centers, which there are many around there. Part of those discussions was a basis for our decision in working with the mayor of East Point to put an urgent care in place as we moved away from ER services. Because the majority of the patients coming in to the AMC South ER really needed primary care, chronic care, social determinants of health support, and food insecurity solutions. So we still have that open, and we're working in collaboration with Dr. Williams at the Southside Clinic on where we grow those services. And then the communication, we did direct mails to the homes of our patients, and we worked with the community neighborhood boards online. So we made every effort, and we got good input from the mayor's office across all of our municipalities, as well as communication with our other health systems as we communicated those transition of care.
Senator Lucas.
Yes, thank you, Mr. Chair. What is your relationship with Medical College of Georgia, since I see y'all were negotiating with them? And that's $105 million in this year's budget that went to part of that negotiation with the regions.
Jim, yeah.
Currently, we are the beneficiary of many graduates of Medical College of Georgia physicians who are on our medical staff. That's our current relationship today. What is being proposed is that Wellstar will become the sole community member of Augusta University Health System. That's what was announced earlier this year, and that's now before regulatory authorities of the state. We are currently two independent organizations at this juncture. As I understand the reference to what was in the state budget, that was an amount of funding to fund a new electronic medical record system for the Medical College of Georgia and Augusta University Health System that was requested by the university system from the state. As I understand it, that request was necessary. It had been requested for a number of years, as I understand it, and is needed regardless of whether ultimately Wellstar and Medical College of Georgia and AUHS come together under this arrangement.
One more question, Mr. Chair. I listened to your presentation, and you said that you tried to work with people about Wellstar prior to the closure of getting money or having partners. Did you come to the state? Did you talk to Dr. Watson, who's in the Georgia Senate? I understand you're nonprofit, but with what Wellstar has done and what has happened in the metro Atlanta area, and us putting $165 million in Grady to try to compensate for those folks, if you had talked to us as state leaders, we might have been able to work something out. You nonprofit, deed a quarter of an inch of the building to the state, and we give you the money.
For example.
As I mentioned, I would respectfully ask the chairman, I did not come here today to talk about individuals or specifics. I will just say that this was over a 3-year period. We spoke with all the local and state officials about the challenges and looked at different things. But
What
we
state
were-
officials? You talked to the governor?
Okay, I did not come here to talk about specifics. I respectfully.
We just trying to
ask.
find out, we're the ones now that are settled with trying to work this situation out so we got health care. And I'm saying, as a member of the General Assembly, and I've been here 49 years, and nobody said a word to me. I just heard about it when the governor did the $165 million after you closed. We listen to people. We get elected. We got a constituents. If y'all had said something to Dr. Watson, some members of the Senate or the House, don't you think we would have taken it very, very seriously in dealing with people in the metropolitan area?
As I sit here today, I can see that, and that's why we appreciate bringing this group together. But I would say to you, we talked with all local and state officials, and it's back to, it would be, and I hear that there's been studies done. You know, you've been studies that happened since the beginning of the year. Would have liked to have had some of those studies done earlier than this, and more health planning. But I did not come today to talk about individuals. If you'd like to have a meeting where the individuals are all here together, happy to do that. I don't see some of my fellow colleagues in the health systems here. And so what we would say to you is, we did our best. As I'm listening to you, you said that there's other things we could have done to have changed this outcome. But I would say to you, we exhausted all options that we were aware of. And as we talked to individuals that we thought were accountable for the health care in Fulton and DeKalb counties, perhaps you have new insights for us today.
Thank you. Senator, let me, Senator Hodges hadn't asked a question that I recall, so I'm going to put him in front of the line.
Thank you. Thank you, Mr. Chairman. Just as a matter of context, Mr. Buzinski, you mentioned a few minutes ago, you said your 6/30/19 fiscal results, you said you had a 5.2% operating margin.
Yes, sir.
And you said AMC had a $16.2 million operating loss?
As part of that, yes, sir.
What does a 5.2% operating margin equate to in dollars
That's
for?
approximately $200 million.
So you made $200 million after losing $16 million at AMC.
That is correct, pre-pandemic, yes,
Do
sir.
you have other service areas where you had similar losses
During that time period?
during that fiscal year?
Pre-pandemic?
During that
Yeah.
fiscal year? No, that fiscal year.
I don't recall any significant other areas. No, no, sir.
Okay. So basically, on a $200 million operating profit, you're losing 16 in the center. So the issue you had was continuing losses of a similar amount as far as the eye could see, plus a really big capital call to replace that hospital. $650 million, I believe you mentioned.
Facility's over 100 years old.
Okay. And you consulted with local governments, you consulted with the state about help in the capital necessary to replace that hospital. I guess you looked at investors, partners, bond market, all that stuff. Okay.
Yes, sir.
Okay. So 16 million on 200, 16 million on 200 million. That's just what I wanted the context. Thank you.
Senator Hufstetler.
Yeah, you talked about $109 million the last year at AMC.
That's correct.
We also had the direct pay funding coming in, and I'm sure we could get this from the Department of Community Health, but what was the numbers of the additional money that was going to bring into AMC? I know Grady was getting quite a bit from it, and I would assume AMC would be getting a significant amount.
Yeah, I don't recall those numbers offhand. There were some preliminary estimates done a couple years ago. At the time we made our decision, we did not have any funding numbers for Georgia Strong or DPP program. That was still yet to be approved by the federal government, and we had none at that point in time.
So these hospitals got money in March, and then about 75% of it, the rest, I believe, by the end of this month or whatever. You guys didn't get that funding because you closed?
That's correct.
Right.
All right.
So Grady and AU got that money in November, right? Yeah.
They were part.
First. Yeah, they were first.
They were first, right.
One other question on the finances, if I could. You said 200 million. The book I'm seeing here has 377 million net operating income, but it also says that excludes PRF and state of Georgia funding. Why is that excluded, and how much money is that?
With respect to what period of time are you referring to, sir?
The booklet you guys just handed out.
Yeah, so it depends upon your period of time. The reality is that the pandemic, you're looking at a pandemic years, and that's what revenue may have been had it not been for the pandemic. All bets were off when the pandemic
So it's
occurred.
21 is what
Yeah.
it is.
All bets were off with respect to the pandemic and the pandemic-induced highly inflationary cost. So as you look forward in time, the CARES Act funds actually relieved some of the lost revenues that we had and had some of the higher costs that we had. But looking forward, fiscal '22, virtually all CARES Act funding had disappeared. And fiscal '23, it doesn't exist. And fiscal '24, it doesn't exist. So what happened is the highly inflationary cost that just skyrocketed as our Piedmont colleagues collaborated, as did Moody's and S&P and Fitch. The reality is those skyrocketing costs at AMC ballooned operating losses to $109 million in fiscal '22 with no government relief from the CARES Act because that had already concluded.
Mm-hmm.
And that
But
was
you hadn't
from
got
which
your direct pay funding yet. They got theirs in November, so it seems like you would know a significant amount of money was coming. And I still haven't heard you say why the PRF and state of Georgia funding isn't in that number and how much money that is.
For fiscal '22, there was virtually no significant government funding for provider relief under the CARES Act. There was some, but it was relatively nominal. So $109 million is inclusive of any of those funds.
Senator Warren.
Thank you, Mr. Chair. This is, I think, a very helpful and an eye-opening conversation that we're having. And the dollars are really the bottom line discussion, in addition to the lives that have been so laid out here in the reports from Morehouse and others. Because at the same time that you're closing down half of the trauma, level 1 trauma in metropolitan Atlanta with the closure of AMC, at the same time, you are negotiating actively and have now come out with the numbers that are involved in moving into the Augusta healthcare delivery system. I understand you've pledged over $800 million to put on the table to be the partner that runs that system. Isn't that correct?
That is correct, over a 10-year period.
That's right. And you were reported a profit margin, but somehow there was no way to find a way here in Atlanta to invest the money. I mean, it doesn't sound like a nonprofit. It sounds like a for-profit approach that you made. And let me say, as a senator who represents the folks who depended on AMC and AMC South for health care, and as a person who's accessed emergency care at AMC up on Boulevard myself, I was never contacted about this closure. And the mayor of Atlanta says pretty much the same thing. And that is a direct contradiction to the narrative that we've heard here today about your extensive efforts. those are my constituents. I live in the catchment area of AMC. I represent that area and have for going on 40 years. And I never heard a word about this crisis or this shutdown.
Senator, we
Yes,
have a question in there?
I do.
Isn't that true?
Isn't that true? Isn't that true
I got
that
you.
y'all didn't talk to me?
Thank you.
Thank you, Mr. Chair. But back to this money that you are putting on the table to make this lucrative, Augusta. You're going to get the ability to launch a new hospital in Columbia County, right? They have the CON to put in a new state-of-the-art Columbia County, representing, serving a massively white population over there. Isn't that true?
With respect to Augusta University and their new hospital, that was long anticipated by the University System of Georgia and Augusta University Health System for nearly a decade, as I understand it, and that was a requirement to the request for proposal that new hospital would be funded by the potential selected party.
And you all are bringing the money to the table to do that. Isn't that the case? It's about money. If you can put in almost $1 billion commitment over in the Augusta, Columbia County area, but you don't have the money to keep open medical treatment facilities here in Atlanta for a population that's between 55 and 71% black. That is why, isn't it true, we filed the charges against the hospital corporation for violating Title VI of
They
civil
probably
rights
can't
because
answer that
because
on
of the can you answer that about the
from a DOJ or I don't want to put you on.
Okay, again, we're familiar. Okay, all right. I guess I understood others didn't talk about it, but we're aware of the allegations. And I just want to stay in this room. They are false.
Thank you.
But I'm not allowed to say anything else.
I got you. I understand. From a lawsuit standpoint, I
just
certainly
Mr.
understand. Any other questions
just
from the committee?
Mr. Chairman, that would be something that the committee, I think, would be well served going forward to get our arms around these numbers. I mean, I don't know how long we have left to talk about it today. I don't think we do.
We're a little bit longer than what we had planned for.
Exactly,
for this. I
and
got you.
because it's all in the newspapers, and it's all before the Attorney General right now for vetting these numbers and looking, and there's going to be a public hearing the end of this month, I believe, the 24th of June or July. There's going to be a public hearing that the AG is holding around this. So the numbers, the dollars are very, very important if the hospital corporation can come up with close to $1 billion and WellStar starts a $100 million health tech fund. There's money that just was not spent here. You folded your tents and walked away.
Thank you.
Isn't it true? Thank you, Mr.
All right.
Chair.
Any other questions, or do you have a question, Senator Brass?
Thank you, Mr. Chairman. Thank y'all for being here. Ms. Candace, you had stated earlier you had y'all had a community benefit of $1.2 billion, I believe it was. Some of your friends watching looked up in your IRS filing or whatever. I think y'all put $375 million or just shy of it. Can you just kind of explain where that other $800 million is and where that comes from?
I'm not sure which IRS filings you're referring to, but the uncompensated care that we deliver of $1.2 billion for the fiscal year ending June 22 is in our audited financial statements. It's fully disclosed. It's on our website. It is audited information, $1.2 billion.
Okay.
It has 4 predominant categories: the cost in excess of Medicare reimbursement, the cost in excess of Medicaid reimbursement, the cost of charity care, the cost of other uninsured people who do not access charity care, but we still provide service, and other community programs. It is in our audited financial statements.
So in other words, the discrepancy is what CMS guidelines does with that. CMS cost versus your cost, which you're saying your costs are. I got you.
And then I guess just follow up real quick, just so I'm following properly in your book, and I don't expect y'all to know this, but I think is this breaking it down by 2021? Y'all had 949 million.
Yes, that would
And
be
then
correct.
that's kind of the breakdown of what you just
That's
said.
correct.
Okay.
Yes, sir.
All
And
right,
it's only
got it.
gone up during the pandemic. That is correct, sir.
Got it. Okay. I just want.
Thank you. Thank you, Chairman. Any other questions? All righty, thank you. Thank you very much for being here. I know that's, it's not easy being Chairman, CEO, and CFO. We appreciate what you do, and thank you for coming very much.
Thank you for having us.
All righty, moving on. Dr. Bryce Gartland, already at the podium. Thank you.
Trying to get you back on schedule here.
Yeah,
So,
I bet you won't take, what, that was 45 minutes?
hopefully it'll be less than that. So,
51, there we go, all right.
first of all, really appreciate the opportunity, Mr. Chairman, as well as committee members, to be with you here today talking about the state of healthcare infrastructure. And I'm going to carry forward a lot of themes that my colleagues have already hit upon. Just by background, I am a physician, internal medicine hospitalist by practice, and serve as the hospital group president and co-chief of clinical operations. So I oversee all of our 11 acute care facilities as well as the clinical shared services. Just for those of you that may not be as familiar with Emory Healthcare, we are the most comprehensive academic healthcare system in the state of Georgia. And I think it's important to underscore that academic component because in addition to our clinical services that we render to 5.6 million outpatients a year, over 100,000 hospitalizations and 300,000 ER visits, we also carry forward the missions of research and education. Just to put some numbers behind that, we have over 6,000 healthcare students and trainees across our Woodruff Health Science Centers. That includes all of our schools of medicine, nursing, public health, as well as our graduate medical education programs. We see over 27,000 patients a year participating in clinical research, which is important, not only in terms of advancing science, but also in terms of a national and international reputation within the state of, for the state of Georgia. And combined between our clinical research and education missions, over $14.8 billion in impact to the state of Georgia. You can see here 11 facilities. That includes the number 1 and 2 hospitals in the state of Georgia, according to U.S. News and World Report. We have roughly 3,500 physicians, of which 2,300 of them are employed, that serve over 250 outpatient locations, 28 Georgia counties. Basically, you name a specialty, we have it. And that's exemplified by, one of the themes from a healthcare ecosystem. About 15% of patients that arrive at Emory University Hospital are acute to acute transfer, which means you've shown up at another hospital and basically been told, you're too complex, we can't handle you, you need to go to Emory. And I think that's important when you talk about healthcare infrastructure within the state of Georgia, is to really think about it from an ecosystem standpoint. And here's just an expanse that shows our acute care facilities, as well as outreach locations with things like the Winship Cancer Network. We're the only comprehensive NCI-designated cancer center in the state of Georgia, which really represents the best of the best when it comes to cancer care. Major challenges that are facing healthcare, and these are not unique to Emory. My colleagues have already hit upon these today. Workforce. Demand far exceeds supply. McKinsey study, 15% of healthcare workforce left. That doesn't mean they picked up and went across and worked at Piedmont or Northside. They simply left the industry. At the same point in time, we've got a Medicare tsunami going on with 10,000 individuals a day becoming eligible, which increasingly are consuming healthcare resources. Just to use Emory as an example, pre-pandemic, roughly a third of our nursing staff was either eligible for retirement or would be eligible for retirement in the next 2 years. Guess what? They did. Guess what? The schools of nursing are not able to generate the workforce right now. So we've got a major mismatch in demand supply. Short term, that's resulted in a lot of contract and premium labor cost. I know Mike Mandel showed the numbers from Piedmont. The ones from Emory, you could Xerox it off. We're in the same $600 to $700 million increase, and that's off a base of about $5 billion a year in terms of cost. Inflation, not just with labor, supplies, and pharmacy. Unlike all the other industries, guys, healthcare reimbursement lags by years. That's governmental and non-governmental. So even if we have private payer arrangements, they don't account for this inflationary time period. That's causing this massive acute pressure that we're seeing right now. I can't increase ticket price. I can't charge a baggage fee. We're caught with what we're caught with. And right now, it's massively disrupted. payers. You want to look at where the profit's going? Look up any single one of the payers in their most recent quarterly reports. How are they doing it? They're not passing the cost along from an inflationary in terms of our rates. They're denying care for our patients. That includes not just kind of hospitalization, but actually denial to post-acute care. Length of stay across most hospitals is up almost a full day. And when you have a diagnosis-related group reimbursement, we're not being paid anymore for that cost of care. What's it equate to? Probably $1,200 to $1,600 per day in terms of increased cost. Timely payment. Guess how long it takes Emory to get paid for a transplant patient? Commercial. Over 6 months. So we have to bear the cost of all that care, and they're not being reimbursed in a timely manner. And again, all of that pushes increased cost onto these financially strained healthcare providers. And I think one of the core themes that several of my colleagues already hit on today is that, you know, unfortunately, American healthcare is caught on a perverse system of cross-subsidization. We lose on 70% of what comes to the hospitals, and you hope to make it up on the balance of the 30%. And if we don't fix that cross-subsidization, guys, this system can't continue to exist as it does right now. And if you look at it, you know, that's where the acute pressures are really coming into place, because in fact, the pressures that we're seeing from a finance cost actually haven't been fully absorbed by the individuals that are carrying commercial insurance or the employers. And that's why this year you're going to start seeing rate hikes of 15, 20%, et cetera. So when you think about it, the last, you know, challenge is, you know, healthcare ecosystem stability. You know, and, you know, I'm very appreciative of our partnership with CEO Thurman and what we've done from a DeKalb County basis and really trying to stabilize the South DeKalb area. But I want to use kind of Emory Midtown Hospital as an example in terms of what happens when a provider happens to shutter services. And again, guys, this is just an example. The same thing could play out across, you know, obstetrical services in rural Georgia just as well. So Emory University Hospital is our facility in Midtown Atlanta. In fact, it's actually the closest hospital to Atlanta Medical Center, closer than Grady is. It's on the same side of the highway. Post-closure, our ER volumes are up 30%. That means 50 more patients per day are coming into our already strained facility. Ambulance arrivals are up 54%. In fact, if you go out, last time I went out to the Georgia Coordinating Center website on this, Emory's actually seen more ambulance increase than Grady or any other healthcare system within Metro Atlanta. That's over an ambulance more per hour. Those ambulance arrivals have about a 50% odds of being admitted into the hospital. The patients that walk through the door, about 21% odds of being admitted into the hospital. Net result, our hospital census is increased by 35 to 50 patients. What's the net result of that? 25 to 35 patients are waiting in our emergency department at any moment in time for beds that are already filled. 41% increased in ER length of stay. When beds are at full capacity, that impairs access for all patients, and I think that's really important for all of us to remember. Guys, I care deeply about the communities, and particularly our underserved communities and what's going on there, but this impacts all of us. If somebody in here has a heart attack, a stroke, and you need to be brought over to another facility right now, chances are you will be backed up and waited. Listen to our EMS chief. He was talking to you about it. And so, you know, it's important for us to recognize that it impacts all of us. You know, we've stood up a temporary ER expansion, 2 mobile units. I'm not proud of it. They're basically trailers. What's our long-term solution? Don't have one yet. Estimated capital impact to expand the emergency room at Midtown is north of $55 million on strained financial times. Increased need for contract labor support patient care. Immediately upon closure, we had to go out and expend about $15 million in contract labor on a short-term basis. And again, these are increased financial strains in an already strained system. You know, I've heard a lot of talk about the directed payment programs. Candidly, we could probably spend an entire day session talking about them. Here's my simpleton version of explaining it. 3-legged stool. You got Georgia Aid, which benefits Grady and Augusta, largely based on Medicaid quality improvement. Georgia Strong, which benefits our teaching facilities focused towards workforce redevelopment. Combined, those programs allowed us to redistribute DISH dollars to basically prop uncompensated care for rural Georgia hospitals. 3-legged stool. Georgia Strong, incredibly appreciative of our partnership with the state, the governor's office, DCH, and our other healthcare partners. The net result is about $746 million in federal funds, again, targeted towards 21 teaching hospitals, focused on workforce redevelopment. But why is that important? It comes back to quality improvement. And here it's aligned with the state's Medicaid quality plan, maternal health with C-section rates, access to care with ER diversion, quality outcomes with readmission. And I think the important item is that while this is a key program for supporting healthcare workforce redevelopment, these programs in and of themselves do not solve the problem. It requires more than that. So taking action. We, like most healthcare system guys, are aggressively targeting that value equation. How do we reduce cost of care and expense, contract labor reduction, non-clinical hiring freeze, voluntary retirement programs, the list could go on, and we could spend time talking through that. I think the key takeaways on this one is providers cannot solve healthcare challenges alone. Just as CEO Thurman was talking about kind of the partnership that Emory's really forged with DeKalb County and trying to extend it, the same thing needs to occur across communities across Georgia, state, county, local authorities, et cetera. What type of support is required? We need county and state direct support for uncompensated care. That is a key driver, particularly when that cross-subsidization is disrupted in the way it is. We need continued partnership on governmental programs such as Georgia Strong, right, that allows us to draw down federal dollars. But guys, those programs are not a guarantee. It requires annual renewal and success of the program to continue to exist. Payer reform and accountability, as I talked about, guys, that would be one that we could tremendously use your help and support on from an insurance and insurance commissioner standpoint. Medicaid expansion. The numbers are favorable in terms of the ability to support it, especially when you've got a directed payment program in place. That is really, really key in terms of ultimately getting as much lift as we possibly can to support the actual cost of care. I think it's important. I'd be remiss if I didn't mention the importance of our academic institutions, right? Clinical care, teaching, and research. You know, that is fundamental and a really important role that we at Emory take seriously. And we think when we're focusing on things like workforce redevelopment, that education mission is incredibly important. Last piece is, in each and every, year, there's important legislation that comes up before you all to vote on from a state standpoint. And we really need your legislative support of ensuring kind of that strong healthcare ecosystem. So I'd maybe underscore that as a parting thought with you all in terms of as legislation is coming up before you, if you can just think about it from a healthcare ecosystem standpoint, and please call upon us as your healthcare partners to really help you dissect of, okay, Bryce, help me understand what's not just the first consequence of that, but what happens 2 and 3 steps down the line when we're thinking about a particular legislative piece. So with that, I'd say thank you and would welcome any questions.
Vice Chair.
Thank you very much for your presentation. I'm going to ask you the same thing I asked Piedmont, and that is, have you guys had the internal conversation about what it would take to make Emory Midtown into some level of a trauma center, and what's the result of the conversations?
Yeah, so we've talked about trauma centers. The reality is no provider can step into a trauma center without county or state associated support. That turning those programs on, and even if there's not a patient day one, the reality of having, continuous neurosurgery covers, continuous orthopedic coverage in-house, 24/7, 365. I think the other part that's important in here, and again, this is, I'm speaking not on behalf of Emory, this is just a simple Bryce opinion, but what's really right from a community standpoint, right? Having two level 1 trauma centers literally 6 blocks apart from each other when we've got a metro Atlanta that's much more expansive than that really comes with planning across, the city and the counties that are impacted in terms of what is the best logistical placement based upon where the calls are coming from.
So we have Grady was not able to be here, so they do have the numbers just year to date for their trauma activation, so their trauma protocols in the emergency room. So they've had an increase just this year of 36%. Emergency department year to date are up 6.8%, and deliveries year to date are up 7.9%. So it is felt across all neighbors. Let me just challenge you and those here and in healthcare, that working with the Trauma Care Commission, which they have pretty good resources and good data, may be the best, what's going to be the answer to helping this metro area handle more trauma, because I mean the numbers are there. Your increased emergency rooms, Grady's increased the numbers, and there we have devoted some money. Obviously, it doesn't cover everything to help with call and to help with the trauma care networks, including neurosurgery call and general trauma call too. That we devoted, that the citizens of Georgia devoted, right? I mean, that's through not only the fireworks legislation, but the dedicated fees that we get from other things also. So that's not necessarily a question, but a statement. So we would certainly appreciate that. Our citizens would, Metro Atlanta would. And listen, when I say the state of Georgia, I don't mean that lightly, because my level 1 trauma care center in Savannah gets those from Henry County or Atlanta when all of you are maxed out. So, and including Florida. So, and certainly South Carolina, because we're on the border. So, thank you. Any other questions from our committee? You have kept it at 15 minutes, but we have one more question coming from Senator Lucas.
Mr. Chairman, with all the information that we've received today, what will we do, or what will you do as chairman of this committee about getting us to look at how we deal with, I call the healthcare crisis. I've been dealing with it ever since I came to the Senate in rural Georgia. That's what I've been dealing with. And now it's been exacerbated looking at what happened in Metro Atlanta and the people talking today about a 1.2 million population just in Fulton County. What will we do, what can we do as a committee as far as trying to address it? I heard the folks from Wellstar say we talked to state leaders. I knew nothing about it. You know, I know they're nonprofit, and it's hard to deal with a nonprofit, but they could have deeded a quarter of an inch of the building to the state, and we could have funded the thing, not had the crisis.
Right, good questions. I mean, I think we need to continue to work through it. Not just me, but the whole committee and appropriations and working with the executive branch and DCH. I mean, I think this is a work in progress. You're correct. Since I've been here, we've been in a healthcare crisis. I mean, I think that's, I don't think an overstatement, but I am somewhat optimistic. I think, as you said, that the directed payment plan and Medicaid waiver in conjunction with both of those, I think that's a step in the right direction. I think continuing to look at aspects relating to trauma care, emergency room visits, federally health qualified centers certainly play a role in this, and frankly, I mean, Wellstar should be congratulated for the aspect relating to Medical College of Georgia and Talmadge, or what it used to be termed as Talmadge or Augusta University, MCG, or the hospital there that has been losing money, yet has a good payer mix. And there are other aspects related to that could be cleaned up. So I think it is a complicated issue. I mean, we all know here healthcare is complicated, insurance is complicated, and they all play a role. So I think we'll continue to do this. We'll continue to do it this summer. We'll continue to do it during session. Senator Art.
I just wanted to acknowledge Emory's incredible role of decades of investment in the Grady health system and the role that your physicians and your residents play. It is incalculable. What you all do, and also to highlight this role of the teaching institutions, and in this modern scenario of the way healthcare is funded or not funded, the teaching institutions have really borne an enormous burden, And I just wanted to flag that.
Yeah,
and
thank you
appreciate
so
it.
much, Senator Arg. I know everybody may not have been able to hear you, but let me piggyback on that. Certainly, Emory has played a fabulous role, doesn't get enough credit from that standpoint when it comes to research and graduate medical education and obviously care for individuals.
And I really appreciate you calling out kind of our service from a Grady standpoint, where we do represent the, I think, over 50% of the medical staff. So.
People see great doctors at Grady.
Yeah, thank you. Any other questions? Seeing none. Last but not least, speaking of graduate medical education, Morehouse School of Medicine, Dr. Errol Crook, Chief Medical Officer for Morehouse Healthcare. Thank you.
Great.
Thank you for your patience. And, you know, if you want more than 15 minutes, you got it. But thank you for being here.
Thank you, Chairman Watson. Thank you, committee. I'm going to do my best to not be redundant, hit high points. I've handed you out some written comments, and but I really thank you for the opportunity to be here today. I am Errol Crook. I'm Senior Associate Dean for Clinical Affairs at Morehouse School of Medicine and Chief Medical Officer for Morehouse Healthcare. I bring greetings from our President and CEO, Dr. Valerie Montgomery Rice, our Executive Vice President and Dean, Dr. Adrian Tyndall, and our Board of Trustees. Morehouse School of Medicine's mission is to lead the creation and advancement of health equity. It's ambitious, and we think it has to be an aspirational goal. We define health equity as giving people what they need, when they need it, and in the amount that they need it for them to achieve their optimal health. For us, health equity is about meeting people where they are, recognizing that we do not all start at the same place with regards to our health. To achieve health equity for marginalized communities takes great effort and a community-engaged approach. And we recognize that community engagement starts with trust, a trust that is bidirectional between healthcare providers and the community. Such trust must be earned by a sustained and sincere commitment to the communities that a healthcare organization serves. These trusting relationships are strongest when the healthcare organization is a genuine part of the community, thriving when the community thrives, and suffering and sharing in the suffering when the community suffers. It is during those difficult times that healthcare organizations should be the co-developer of and a conduit for those solutions to their neighbors' problems. We are proud at Morehouse of our commitment to engagement with marginalized communities, particularly in the Atlanta metro area, but actually well beyond these confines. Indeed, most of our students are from communities that are marginalized in some way. And that's very unusual for any medical school in the country to say. We have our 4 historically black colleges and medical schools in the country, and they really are among the only ones that can say that their student bodies are majority from marginalized communities. So we serve a very special niche in that. Because students that come from such backgrounds are much more likely to serve in those backgrounds. As such, large numbers of our alumni are active in rural Georgia and in underserved communities across metropolitan Georgia. Our research enterprise is also very focused on understanding where health inequities are greatest, and we do it from several standpoints, trying to understand how to better come up with better testing and diagnostic and treatment methods, but also, and perhaps most importantly, we are proud of the fact that Morehouse School of Medicine is a leader in creating and distributing best practices in community engagement. Our work enables our partnering communities, local, regional, and globally, to take full advantage of the healthcare resources that are available, even when they're sparse, and how to create solutions when those resources are not up to par. Morehouse School of Medicine has long recognized that marginalized communities in our metropolitan area have fewer choices for where and how they get their health care. The people in these neighborhoods have fewer providers that share their cultural identity than you would see in better resource communities. Over generations, this inequity of opportunity and resources has contributed to early morbidity and, unfortunately, premature death. This reality is, in fact, the basis for the founding of Morehouse School of Medicine in 1975. While Morehouse has contributed significantly to the advancement of health equity in these communities, there remains much more work to be done. With the loss of important healthcare resources in Central and South Fulton County, Morehouse School of Medicine intensified its efforts to achieve health equity. And as you've heard earlier, this led to a partnership with Fulton County and facilitated by consultants EY. And you heard the story, and I won't repeat it here in detail, of the disturbing disparities that exist between the northern parts of Fulton County and the southern part of Fulton County. In short, your zip code determines a lot about what your health and your life will be. And the other important piece to point out is the people in South Fulton County and Central Fulton County also have a lower health expectancy compared to the rest of the state of Georgia, by 4 to 5 years less. So these disparities require addressing, and the solutions will have to be comprehensive. Indeed, the paucity of the healthcare facilities and providers is exacerbated by the fact that many people in South Fulton County also suffer from the social determinants of health, and great social depravity calls for a very comprehensive solution. Some may argue that addressing the social determinants of health are beyond the scope of healthcare institutions, but we at Morehouse School of Medicine, and I believe most other academic and healthcare institutions in this country now, clearly argue otherwise. Healthcare organizations and providers must address these social determinants if the patients and communities they serve are to achieve their optimal health. So we look forward to participating in creating this comprehensive solution set and for the people of Central and South Fulton and for rural Georgia. We pursue solutions that will create sustainably healthy communities. And today I want to highlight 3 areas where more focus is required to achieve this objective. Now, I'm not saying that these are the 3 answers. The answers are much more than this, and I've picked these 3 to highlight. So there must be focus on training more culturally sensitive providers to serve these communities well into the future. There must be more focus on paying attention to the social determinants of health, and there must be more focus on creating greater access of quality health care for those who live in these healthcare deserts. All of these are equally important and clearly interrelated. So Morehouse School of Medicine is excited about the expansion of its educational programs that will bring more culturally sensitive providers to the marginalized communities. We have a new physician's assistance program that has already graduated their first class, and we have grown our medical school significantly over the course of the last several years and have plans for it to perhaps double in size again over the next decade. Moreover, we're excited to have started new graduate medical education programs that provide more opportunities for our medical students and medical students from elsewhere to train and serve right here in Georgia. And perhaps the biggest determinant to a provider having their long-term practice in Georgia is the fact that they train right here in Georgia. So we're really excited about those opportunities. Now, graduate medical education is typically funded mostly by the federal government through the Centers for Medicare and Medicaid Services, and that's recognized. But there are opportunities for state and local governments to support and incentivize trainee programs that will direct or at least incentivize trainees to move into marginalized communities. So examples are scholarships and loan forgiveness, programs that support students with a period of service to under-resourced community. These often have result in long-term commitments to these communities. And also there are opportunities for state and local governments to directly support graduate medical education programs. Morehouse School of Medicine has been a recipient of such program support, and we look forward to expanding such funding with the specific objective of providing more providers to needy communities. So we think GME graduate medical education should be expanded, but done so in a smart way so that we direct more resources where they are most needed. As mentioned above, healthcare must consider the social determinants of health and service to the individual patient, and when considering community health, the presence of depravity in income, housing, food, employment, etc., is the equivalent of a chronic disease, like diabetes and hypertension, okay? And unfortunately, as insult gets added to injury, in that you've, among those communities that have high social depravity, you have more prevalence, meaning exposure of those chronic diseases, and their outcomes are worse. So there's this never-ending cycle that must be disrupted. We believe, we are proud of our partnership in educating the nation's healthcare systems on the importance of these social determinants. And given the financial resources consumed with healthcare that you've actually heard today, healthcare organizations must partner with community-based organizations, governmental organizations, and communities themselves to solve these very complex issues. There are examples of how healthcare organizations have done this, such as providing transportations for patients with challenges to get to their appointments, implementing telehealth solutions to broaden access, providing medications at low cost, and even more novel is actually investing in low and middle income housing for those communities that don't, where they have high percentages of people with housing insecurity. One novel mechanism I'd like to highlight today to address the social needs of patients in these marginalized communities is the incorporation of the community health worker into the healthcare practice. Morehouse School of Medicine is proud of its leadership in developing training programs for community health workers. When you talk about a community health worker, we're talking about someone that has one foot in the community and another foot in the healthcare system, but their focus is actually on the patient. And they facilitate what is necessary for those patients to have optimal health. We are proud to have these training programs, and we are active advocates for healthcare systems across this nation, finding places to engage them as employees to improve patients' outcomes. Importantly, when we talk about community health workers, these are typically people who are underemployed and come from the community in which they live, or in which this healthcare organization is based. And so you're doing actually sometimes 10 times the good by providing a job and an uplifting to a underserved community. Lastly, we'll talk about access. And we recognize that the people of South Fulton County live in a healthcare desert. And the people living in such deserts deserve choice as to where they obtain health care, as choices raise quality and accessibility. They need access to quality primary care, as primary care can focus on prevention, but and then secondly, early diagnosis of those chronic conditions so that we can prevent those untoward complications of those conditions. As you heard earlier, we have had our partnership with Fulton County, and as part of our solution set and to provide more access and resources to the people of South Fulton County, we are partnering with Fulton County to open a clinic in East Point. And we hope to have that up and running within the next 4 months. So ambitious task, and I'm confident we're going to get there. We just see this as the initial step to addressing this healthcare desert, basically trying to make it an oasis. And interestingly, I want to add that we will be implementing community health workers as employees, and also another novel community health worker training program within that clinic so they can actually address the social needs so that patients come into that facility. Now, lastly, I would say that access is not guaranteed solely by the presence of healthcare providers and healthcare facilities. It is also dependent on financial resources. We at Morehouse School of Medicine believe that Medicaid expansion is essential to promote access and choice for all Georgia residents. Implementation of full Medicaid expansion will remove many barriers along the journey to health equity. So again, Mr. Chairman and committee, I thank you for the opportunity to speak today. Morehouse School of Medicine stands at the ready to bring optimal health to all those in marginalized communities, and I'm happy to respond to questions.
Thank you. Appreciate that, Dr. Crook. Question?
Hello, thank you. Thank you very much for what you shared. I want to, just first congratulate Morehouse School of Medicine for the work that you're doing in creating doctors that can be culturally sensitive. As you said, you are in fact, if I'm correct, one of the nation's leading educators of primary care physicians.
That is correct.
So that is something to really applaud. And it's something that we know that we need more of. I represent neighborhoods across Fulton County, particularly as well in our now desert area. So I appreciate the relationship with Fulton County. And it strikes me that Morehouse School of Medicine really is, if not the only medical school that we have in Georgia, then it's one of maybe only two that don't actually have a hospital affiliation, which strikes me as a huge missed opportunity. Wondering if, despite that, you have actual specific kind of formalized partnerships with the other hospitals that are in this region, specifically Fulton County, to address some of the concerns that we've been talking about all morning and now afternoon.
Yeah, we appreciate the question. You're right. In fact, Morehouse School of Medicine is one of the few medical schools in the country that only has a primary hospital partner that is only a Grady type facility. Okay, and so Grady ultimately is our university hospital now. I would say that many of our providers actually did use AMC, both hospitals, and Emory hospitals, and they still do. They feel the crunch at Emory Midtown in particular because it is very difficult to get non-urgent procedural cases done because of just how crowded that hospital is. So there has been a lot of thought given to that. Our president, Dr. Valerie Montgomery Rice, is, if anyone knows her, knows that she's very energetic, aspirational, and will not settle, and has worked hard at developing those relationships. It's been, I think, a part of Morehouse Healthcare's legacy since 1975 to understand what those relationships will be, and we are looking continuously. We talk to anyone who wants to talk to us. We are very appreciative of the fact that other hospitals, all hospital systems in this area have been partners with us with our educational system, for not just for medical students, for our Masters of Public Health students, and for our PA students, and even for our PhD students in doing research. All of them have provided opportunities for training. But the bulk of our work for graduate medical education and for our medical students happens at Grady Hospital and the VA. And I can speak to the point that our trainees, having been on the front line, and not really having that many other places to go, have really been hit hard through the pandemic and the other things that have impacted the increased volume there. They are suffering burnout at an early part of their career, and it really takes a lot of effort on our part to give them the support that is necessary to keep them up and to hopefully keep them focused on why they went into medicine in the first place, is to serve those under-resourced communities. Because when you get there and get hit with that so much, it doesn't take much to flip the trigger to say, I need to go to a more comfortable environment. So thank you for your question.
Senator Wright.
Thank you, Mr. Chair. Thank you so much, and for the patience of waiting this long to bring your information, but for the role that, as my colleague just highlighted, that Morehouse Medical plays is invaluable and has been steadfast since the day of its launch. And you're approaching your 50th anniversary now. Could you speak just for a minute about the the partnership that you flagged with Grady and Emory and Morehouse, both working together to put your students and your doctors in those. But I know that you're now launching, and the state dollars are in nursing
Yes.
training, and your footprint in Columbus.
Yes.
That is something that probably many are not as aware of.
Right.
Thank you.
Well, thank you. So we are in the investigatory stages of looking at a nursing program. As I mentioned, we have public health, PhD programs, and now the PA program. So the next thing Dr. Montgomery has on the plate is nursing, and we are optimistic that we will have that at Morehouse School of Medicine also. Quite frankly, I think all of us would believe, we talk about the allied health, but it's really nursing that's the one we have such a big, huge challenge in across the board, and we're excited about that opportunity. Again, in doing so, we'll be getting folks who may not have had opportunity to pursue those careers to do that. We recognize that's our job at Morehouse, and we develop pathways into our school, and we do have significant support systems to get them to where they need to be so that when they come out as graduates, they are comparable to any other graduate in the country, and we think in many ways better. We are moving to regional campuses, not just around Georgia, but actually across the country through another partnership with a group called Common Spirit. But across Georgia, we do have a regional campus growing in Columbus, Georgia. We're excited by it. Part of this is necessitated by the fact that we're growing our medical school to a point that we have to have new places for clinical opportunities and learning opportunities. Several of our students are going to also go out and be in rural areas. Many of our alumni are the only doctors in that county. And so having the variety of opportunities that are apt and that are appropriate to support them and give them exposure to where they're going to go in practice, we think is incredibly important. So, thank you.
Thank you. Any other questions? Thank you for being here. Thank you for going last. And last but not least, but certainly appreciate your input. I want to thank everyone for hanging in, committee members and those in the audience, especially the interns that are here with us today. I saw a few yawns, but hopefully it didn't put you to sleep completely. But if there's no further business, meeting is, wait, I'm getting reminded. Yes, meeting is adjourned.